Well, good morning, everyone. As you're all aware, this is the fourth virtual MIECTS Symposium. I'd like to welcome all of our national and international viewers. I'm currently speaking to you from London, Canada, London, Ontario, at 9 o'clock in the morning. And again, I'd like to welcome you all for this, this virtual symposium. As you're aware, we have, this is an asynchronous meeting, and all of the lecture topics and the lectures have been posted on the website. So if you've had the opportunity of reviewing these before today, then you'll be fully informed as to how we'll be discussing the various topics. And if not, or if there's areas that pique your interest, you will certainly be able to go back and review the relevant lecture topics as they're all posted online. Also been informed that this session is, of course, being recorded and will be available on the MIECTS website. It's also available on CTSNet. What we propose to do is we will have the various sessions throughout this 3.5-hour event, and we will be having the moderators as well as the various speakers for these topics available online, and we'll be having discussions regarding these various topics. I certainly invite you, the audience members, you can submit any questions live, and we will get to these through the, we'll provide these to the moderators, and so your question can be discussed by the various panelists. So what we'll be doing very shortly is starting the first session. As I say, the program will also include the awards for the top 3 abstracts. We're very pleased that we've had 11 abstracts submitted. These will also be published along with an overview of these proceedings in the journal Perfusion, which should be available within the next few months. We believe that the ability to present abstracts to this international forum is one of the featured aspects of this this program, we will be having further such programs in the future, and so would strongly encourage all of you to consider submitting an abstract to this meeting for future presentation. We'll lastly have some business to attend for the MIECTS Society. And again, I would like to invite all of our registrants and attendees to join MIECTS. This is a multidisciplinary international society which is focused around the advances in perfusion technology, primarily the circuit, but the concept of the society overall is trying to make this a much less invasive procedure from the start of the patient's entry into hospital to their subsequent discharge and longer term follow-up. So we certainly invite all of you to register and join the society. There is no registration fee; it's entirely free, and we do have a live meeting every second year. What we'll be doing very shortly is commencing with the first program, which will be really an overview of the state of the art of MIECT, and it'll be moderated by myself and Dr. Cadner, if he is currently available. I think we will get started now with the first program. So I'd like to take this opportunity to introduce now one of the founding members, the past president of MiECTS, Professor Kyriakos Anastasiadis, who will be talking about MiECT, an overview, and we'll make a few comments regarding that, and then we'll be discussing some of these aspects.
Well, thank you, John, for the introduction, and thank you for the opportunity. I'm currently in Thessaloniki, and we are here with Professor Argyriadou and Mr. Van Driel, trying to reproduce what MiECTS is advocating, a multidisciplinary approach towards this technology. So if I would give an overview, a short overview of what is this technology about, I would say that the last 70 years that the cardiopulmonary bypass was introduced into the clinical practice and pushed forward cardiac surgery, there was a really significant improvement in advancing patients' care in cardiac diseases. Though there is still some adverse events coming from the artificial surfaces that, let's say, are inevitable due to the thing that when we operate as cardiac surgeons, we need this device to take over the heart and lungs. Because of this, any initiative towards improving this process by having more biocompatible means definitely is towards the right direction. And that was the incentive behind establishing this society 7 years ago from all the people that are really involved in the cardiac OR. So from the first beginning, we tried to define this technology as a multidisciplinary approach and not just a perfusion technique. And for this, we wanted all the stakeholders like the perfusionists, the anesthesiologists, the surgeons, the intensivists, the industry to come together and try to implement what we really want to go for, and this is advancements of patient care. So for this, I believe that MiECTS, by defining what is actually the circuit, trying to categorize into 4 generations and try to integrate all this into a strategy by utilizing all peripherals like monitors, like all the techniques used by the different disciplines, helped the international community going to what we have said some years ago with you as a more physiologic perfusion and more physiologic cardiac surgery. So this is ultimately what we believe that we should opt for, and the major impact that this society had towards this technology is what has been emerged into the literature as the optimized ECC, extracorporeal circulation. That means we should abandon what Gibbons had introduced as the conventional CPB, going to as much advancement as we can to reach to the ultimate tool, which for me is MiECT. And of course, definitely going for the quest of the most optimal perfusion towards a more physiologic cardiac surgery. So this is my overview towards this technology.
Excellent. Well, thank you very much. I think one of the challenges we face is the fact that in many centers, particularly in North America, there's a perception that we tried these mini circuits 10 or 20 years ago, and there were a number of challenges, let's say, with air handling, blood handling. And in my estimation, one of the most important advances we've made is to recognize that this is actually a modular component, so that we can now include air handling devices and reservoirs to deal with excessive blood and volume. So with that brief commentary, perhaps Pascal Stanieri would like to make some comments about the perfusion state of the art.
Hello, everybody. Yes, and I agree also with Professor Anastasiadis when he's talking about it's a strategy. It's a team approach, And I think using MiECT systems, you are forced using a certain strategy. And in my opinion, it's the strategy that works. And also we started 9 years ago doing MiECT. And also in the early days, there were some concerns about safety. And also Dr. Merkin, it was air handling. And if you look at it nowadays, I think we worked a number of years with the Livanova S5. Currently, we are also using Spectrum Medical. And if you look then at the machines nowadays, I think they are fully equipped with safety management there. So, and also for us, for our center, what we do is we do the combination between MIECTS and MiECT. If you see my video, you will see that, let's say 8 years ago, we did, let's say 300 cases. Now we doubled it to 800. So the focus is on MIECTS. So minimal invasive cardiac surgery is very important for our center, but also the combination is possible. If you do endoscopic mitrals, endoscopic aortics through RAD, through mini stenotomy, everything is possible if you can use MiECT system. So just sit together as a team. It's always that. It's communication. It's a team approach, and then it's easy to handle. So I think yeah, it's we've seen all the advantages and so on, and also I think safety nowadays is not an issue anymore. So that's a little bit my point of view. So the combination MIECTS and MiECT is perfectly possible. So I hope, yeah, I hope in the future, I think a lot of centers will adopt it, and also the cardiac surgeons. I think those are very important who are performing MIECTS. So.
Yeah. Thank you, Pascal. I think that's the really one of the main points that we really do need to get across is that these the modern circuits, the modular approach to the MiECT system has enabled us to really make the whole procedure substantially more safe. And as you're speaking to, the ability now to do virtually all procedures using the MiECT system has been well proven. So I think those new introduction of all of these various safety features is I think one of the most important concepts we really need to get across as we move this whole approach forwards. And I think as we're going to see from some of the following lectures, the advantages of the reduced blood-air interface in reducing inflammatory processes, et cetera, has a number of physiologic advantages which translate into improved clinical outcomes. So that will be forthcoming in the subsequent lectures. At this point, perhaps, as we're speaking about how to introduce and optimize this approach to patient care, perhaps we can get Professor Thierry Carrel to speak to his experiences using this as a team approach.
Well, John, I think that Thierry has something out of the sudden, and he cannot attend from what he has told me. So if you want me just to have a small comment on what you have said on behalf of Thierry, is that what we have advocated from the first beginning is that this technology should go for a team approach, because it's not just a demanding technology, it's something really innovative. And if you want to have the maximum benefit, you need to have everyone on board. Otherwise, you cannot do it. That means, of course, first of all, you have to appreciate what is this technology about. And this is not only for the perfusionists, it is for the surgeon and anesthesiologist as well. Second thing is try to adjust your own technique for the sake of this technology. That means not just to be meticulous, but sometimes to modify what you are doing so as not to interfere with the technology itself. And third is trying to have a strategy for obtaining this best result that we advocate. That means monitors are just devices. They cannot think, they cannot translate themselves. They need someone to take under account everything and also have a plan. And this plan has in the middle this perfusion, but in the outer circle, it has a strategy which is multidisciplinary. So the term teamwork really applies here, where this technology unites the three disciplines and try, let's say, to bring forward what is the meaning of cardiac surgery, which is trying to operate with a non-physiologic way to a patient that needs the maximum from all three stakeholders of the surgical OR. And this is the way that we approach it. And I believe what this technology brought into the literature as a discussion is that the teamwork is necessary, not just for this technology, but for all other issues that are regarding the surgical OR, and especially the cardiac surgical OR.
Yeah, well, thanks very much for that. That's a very important perspective. I think there are two main messages. One is that the whole team needs to be open to modifying their approach. And as you say, it is a team effort. And I think that's why, again, the society is so important. As a multidisciplinary society, we're bringing together cardiac surgery, perfusion, anesthesiology, industry, and potentially intensive care. Because at each step, the management of these patients has to be governed by similar principles, that we're trying to make this minimally invasive. And for my anesthesia colleagues, that means very significantly trying to limit, for example, the amount of fluids patients are receiving. So I think there's a number of strategies that we'll be learning about as the morning progresses. But I think we have a comment from Professor El Issawi. So Ashraf, did you have a comment?
Yeah, I have just a small comment. At the end of the day, we're not dealing with mathematics. Mathematics will 1 + 1 will always give 2. But if as a team, we don't know what the others, what goals the others are seeking. And if I'm not, I could be counteracting the role of the blood patient management that the anesthesiologist is approaching. I could be adding to it. And at the end, an optimal team approach will result in a synergy that will add 1 + 1, making more than 2. And it is this synergy, this added role, that will end up in an optimal outcome. That was it.
And I wonder, when we're talking about a modification of approach, what particular aspects, from a surgical standpoint, is it a very significant change we're talking about, or are these relatively subtle modifications when in dealing with this type of circuit?
I think it starts up when it depends on what you're doing. At the beginning, you will obviously start with cabbages. Then the modifications are really small. So you have to be aware that patient blood management, your contribution to patient blood management is not having a cardiotomy suction. It is reducing your transfusion requirements and reducing your blood losses. At the end of the day, we are all emphasizing a team approach. However, at the end of the day, the surgeon is the gatekeeper. The two Achilles heels of a MiECT are air getting into the system and blood getting out of the patient. And at the end of the day, it's the surgeon who's the gatekeeper. But regardless, if I don't take this seriously, and there is nothing a perfusionist or an anesthesiologist can do to compensate for that. Then once I started doing redos, I had to reduce blood losses around my cannulation site. So I had to use different cannulas. I used cannulas with a cone tip so that I would dilate the axis rather than tearing it up. I used the Seldinger technique. Later, when I did mitral valve surgery, I realized that I'm too often getting air into the system through the superior cannula. But at the end of the day, the superior cannula goes into the superior vena cava. This is the thinnest part we are cannulating in our whole lives. When we cannulate the inferior vena cava, we're always going through the atrium. So this is not a problem. So I started introducing a straight cannula, wire enforced through the right auricle and passing it up to the superior vena cava. Once I did that, I had no problems with air handling anymore. So these are things you have to adapt to. You have to communicate better, and everyone in the team has to see how he can add to the goals and of the others.
I think those are very, very important comments. As I say, I think all of this starts with the recognition that we can do better in comparison to the conventional bypass circuit. And I think that's, again, what's so important about these type of symposia is to underscore the physiologic and ultimately the patient outcome benefits that we see by utilizing this type of approach. And once we have become aware of these potential advantages, then the necessary modifications to techniques are relatively willingly undertaken. The challenge always is to provide a solution if there's really no recognition of a problem. And I think that's why as more and more literature is published showing reduced transfusion rates, reductions in lengths of stay, and these various outcome measures, up to and including the COMICS trial, which we'll be talking about later on in the program, the advantages that have been seen so far, once they become more aware by the various clinicians, then these types of modifications are relatively acceptable and relatively minor. What I'm hearing from you, Ashraf, is paying attention to these smaller details becomes increasingly important when we use these type of circuits, but they're certainly manageable.
Well,
I totally agree with that.
John, if I may, I can categorize the surgical input into four categories. So a surgeon should be meticulous. The major issue here is that we don't use cardiotomy suction, or we try to avoid cardiotomy suction. So he has to be like the off-pump surgeon, very careful about the blood that can just escape from the circulation. So first of all is the shed blood. The second category is the air tightness, as Ashraf has pointed out. So he needs to know very well the techniques so as to have no blood, no air interaction, because this system does not allow to have air into the system. The third is the ventings. So the vents is very important for the perfusionist when he's utilizing this closed system, because the patient himself is the reservoir. He needs very well volume management so as not to have the blood flooding to the field of the surgeon, but also to have an alleviated heart and perfusionist to be, let's say, comfortable with what the surgeon is doing. And the fourth is the access, as also Ashraf has pointed out. And I can tell you another example from what he said about the cannulas. As also he said, the more advanced surgery you are doing on the mini systems, the more adjusted you have to go for to your technique. And an example is the mitral valve surgery. When I started doing that with MiECT, I had to switch from left atrial approach to transeptal approach, because that helped me a lot, not retracting the cannulas and having air into the system. And after using this transatrial approach, I never had a problem. So with these four categories, I believe we can reproduce what we say about surgical input to the system regarding our technique.
Yeah, again, I think those technique modifications are, as you point out, very, very important. And as I say, the underlying challenge is to persuade one's colleagues that it's worth the effort to make these types of modifications in order to use this circuit, that the benefits of this approach are significant and are worth learning how to respond to this this different circuitry. And I think that's one of the reasons we have the next speaker. I'm not sure if Professor Punjabi is available for us, but we were going to be having an update on the literature. Oh, there we are. Yeah. I think as we talk about one of the important aspects as we speak about MIECTS or MIECT systems is understanding some of the benefits that are being seen in the literature, and perhaps at this point, Professor Punjabi would like to give us a bit of a literature update, just to talk about some of the key benefits that are starting to become apparent when we review the types of experiences that people are reporting.
So thank you very much. I hope you can hear me well. I'm terribly sorry for my delay in the confusion about timings. I'm so sorry, but I'm here and I'm quite keen to start. Thank you. Well, absolutely. I think so. I just wanted to start off by giving you a little bit of overview of how we as a journal are doing and a little bit of what the general literature is. I'm very pleased to see a lot of members here who are very much contributing as well. And we've had a good number of manuscripts within the Perfusion Journal. So as sort of editor-in-chief, as of today, and part of the reason why I didn't actually make, because this is such a constantly changing field. So I thought I'll give you an update of the latest numbers and, manuscript types that we have. So perfusion has been growing every year. And last year, for the first time, we had 440 manuscript submissions with an average acceptance rate of around 45%, so 50 to 55% of manuscripts. So I think it's just a reflection of the quality of scientific content. But today, as of this morning, I've had 236 submissions. So we are talking about 26th of June. We start counting on the 1st of January. Sometimes it does change, sometimes. But if we were to follow this trajectory, it looks like we are going to cross 450, which was 445 last year, which was the first ever year we had crossed 400. So it looks like there is, and I think it's a combination of things, pandemic and various scientific interests. But the most important one is the emerging use of intensive care manuscripts. And within that, clearly the extracorporeal life support. But then the description of the circuits within the surgical field as well as within the intensive care is really very fascinating. And I'm finding a lot more manuscripts coming with mini invasive circuits because it is almost everywhere. It's universal. It can be applied not just in the OR. It is applied now. We are seeing a lot on mobile systems. And it's amazing how the transfer of knowledge, if you want to call it, and the adoption from various colleagues is happening. And all this is, sort of ideas that are born and taken from the OR and development of different cannulas and oxygenators that are going on. So I think this is a very exciting field, and many circuits apart from the OR, as you were just talking about the surgical, and I just wanted to give an example myself. Literally yesterday, I had to operate on someone who was severely anemic, and needed a coronary bypass grafting surgery, was only 44 kilos. And we actively, we have the facility. And so all my team and my perfusion actually said, well, we can't do this without using a mini circuit. We have to use a mini circuit because we've got to minimize the dilution and keep the hemoglobin. Patient had severe anemia. So I think practicality wise, you can see that we are doing that. And I'm sure a lot of my colleagues are doing that, not just by way of passion, which is, yes, everybody would like to, but there is an emerging need. We are seeing more complexity of patients, and we are just answering to the complexity of the patient. So it's such a perfect match that we are at this moment now, having spearheaded for the last 5-6 years, but now it is just becoming a natural choice because it has got so many advantages that have been borne out in literature repeatedly, and you now find you don't really need to encourage. Just literally this week, earlier in the week, one of my colleagues who doesn't do much, but he came over and said, I've got this complex patient, infective endocarditis, I've got to do a double valve. Do you think mini invasive will allow me to do that? And I said, sure, absolutely. I'm just in the next OR. I popped in. The perfusionist was very happy and the surgeon was very happy. And so I think we are, by way of necessity, which is a key point, which is the best sort of step up forward you can find, because no more now you have to go and profess the advantages. People are looking at it and saying, oh, he's been doing it for quite some time. What's that? What's that? Do you think I can use it? Do you think this? So it's just a natural spread. And of course, at the same time, it's being complemented very heavily with manuscripts. Now, we've seen, pandemic, COVID, intensive care and all that, but there has been a spurt in the number of manuscripts that we have seen largely in the literature world. People have had more time, people have had a lot more science, and there has been, certainly in specialist journals like us, we are seeing more and more manuscripts that are specifically targeting not just on the anemia and the use of hemoglobin, but I've seen adoption of new cannulas, adoption of inflammatory response, evaluating delivery of cardioplegia. So you're actually now talking about comparing cardioplegia between the circuits. So it's not no more as a circuit comparison. It's like move to the next level where we are comparing cardioplegia using the same circuit and trying to look at the differences, subtle differences, which means that the mini circuit is standard. By default, it has to be a standard because you want to now move to the next level of comparing the use of cardioplegia. So that was another manuscript that I wanted to share with you. So I think personally, from what I see, this is now becoming more of a need of the hour because of the various patient population that we are seeing, the various comorbidities that we are seeing, and then the use laterally by our colleagues in anesthesia and intensive care and perfusion, and some parts of cath lab. So we've had some manuscripts that have had the use in cath labs. And they are all with the principle of minimizing everything. And of course, the idea has born from the use in the OR. And I think it is just going to go back and come back, because the moment they start doing that, it is going to filter back to the OR, and they will almost universally become a standard in the institution. So we are now pushing so that if you by default, the standard is mini, and that, of course, you have to tell and make a reasoning as to why you don't want it, rather than the other way around. And I think over the years, it was more and more convincing needed, but now, oh yeah, I'm comfortable. 5 of my colleagues here, and they're all saying, yeah. If you think that's the best thing, why don't we just do it? And I mean, what it means is they are not seeing it as a hindrance when they are operating. They are not seeing it as an issue, and they are just looking at the advantages. And I think once we reach that, we are there. I don't think I want to say once we reach that, I think we are there. And I think that's key. That's a very good place to be. And I think as an organization, MiECTS has been promoting that. And I think some of the manuscripts, classification, type 1, 2, 3, 4, have been very, very helpful. And I think defining, because confusion over definition exists quite some time, but we are getting much clearer idea. Everyone adopts and has their own circuit, I guess, but we clearly have a circuit that is very much in the mini range, and we've shrunk the priming volume, everything, and we almost do not use any suckers. So as discussion was going on, a little bit of minor modifications and adaptations, but once you are happy and convinced that this is actually good for my patient, then you don't see as an hindrance that adoption. That adaptation or adopting becomes a easy thing, because it's like I like to do CABG on cardioplegia. Now there are different kinds of cardioplegia, but I'm not off pump. So it's like I want to do everything on mini invasive. There may be different types, but it's not standard. So I think that's where we are. So I'm terribly sorry for the delay, but it's a nutshell of what I'm trying to give, and I hope that's been helpful. Thank you very much for this privilege.
Prakash, thank you so much. I think that was a very important perspective. As you say, you have the opportunity, and congratulations on the journal. We're all very pleased to see this increasing success. And I think your comments are very well taken, because it's that combination of reporting on the various positive aspects of using this type of approach and technology that, as you say, it's now become a solution to problems that clinicians see. And previously, again, it was almost an approach looking for a looking for a problem, and all of the other issues with the progressive iterations of this type of circuitry and technology have now gotten to the stage where it is very safe. It can be used for a variety of approaches, and as you've pointed out, as the institution and clinicians get more and more experience, you recognize the particular benefits that can be achieved by this type of approach, and so now you're using this to solve problems in a variety of other areas. And so perhaps with that introduction, we'd like to close out this session now with Dr. Antonitsis. He'll be talking about modular MiECT, which I think has been the real key in moving this technology forward and enhancing the safety thereof.
Yes, thank you, Professor Merkin. And first of all, as the Secretary of MiECTS, I would like to welcome all those who are actually live now, all those who participate, and all those who watch this type of asynchronous and virtual symposium. So very, very briefly, I would like to take the opportunity to refer to the presentation that you can watch, actually, that is available online, and you can watch in great detail. And the aim of the presentation and the aim of this presentation of modular MiECT is to answer to Elezawi's question. So what is the magnitude? What is the real problem of air going into the system and the blood going out of the patient in the era of modular MiECT? And we actually tried in Ahepa University Hospital under the whole team, guided by Professor Anastasiadis, to give a reply to this question. So we have actually studied data from 403 patients, all cases, all comers, including emergency cases, including type A aortic dissection cases, including frozen elephant trunk cases with high-risk patients in a significant percentage, and with almost 40-something% of coronary artery bypass grafting and all the other cases complex performed with modular MiECT, to see what is the magnitude of air entering into the system or from blood coming out of the patient that can cause conversion to an open circuit. And what we saw is that, first of all, modular minimal invasive extracorporeal circulation secures that all operations can be performed with 100% technical feasibility. And the true conversion rate, if we exclude the cases of aortic dissection that needs for the circuit to open, the true conversion rate in this big series, the largest series reported in the literature of 403 patients, is 4.5%. So literally, for 95.5% of cases, the surgical community can use a type 3 closed minimal invasive extracorporeal circulation circuit, while for 4.5% of cases, using a very, very liberal strategy, when air is going in or blood is excessively coming out of the patient, then this can be converted to an open circuit. And the second question is, how long do we need this open conversion? How long do we need this open configuration? And the answer that we give in this very, very large series is that the open configuration is required for about 40% of the operative time. So this means that for the majority of the operative time, the system can become closed again and let's say have all the benefits of minimal invasive extracorporeal circulation. So the concept that we are trying to disseminate into the surgical community, to this cardiac surgical community, including the anesthesiologists and the perfusionists, is that in order to get the maximum benefit of this technology, in order to gain the maximum benefit of minimal invasiveness, not only in the surgical approach, but also in terms of a physiologic approach, then minimal invasive extracorporeal circulation is the cornerstone for getting all these benefits. And this is actually documented when we've done a systematic review of the literature, and we've seen that the other series reported, let's say, a conversion rate of 2%. So we believe that the rate that we have observed is more close to reality. So we can say that almost more than 95% of the procedures can be performed by using the minimal invasive extracorporeal circulation configuration, and then we can actually aim for a more physiologic cardiac surgery if this is combined with minimal invasive cardiac surgery, as Pascal said. So this is the main message from my presentation. You can view it online, and of course it will be available for comments later.
Thank you very much, Polychronis. And again, I think that's the point we want to keep reiterating, that all of these lectures are available for review, so that if you haven't had the opportunity before, please, if we pique your curiosity with some of the comments or presentations that have been made, you can go back and review the original lecture.
Yes,
it's now time, thank you very much to all the speakers for this first session. It's now time to introduce session 2, which will be moderated by Professor Liebold and Bennett, and we'll be talking about MiECT, the why, what, and how. So thank you, and stay tuned.
Hello, everybody. Welcome to the second session entitled MiECT, Why, What, and How. My name is Andreas Liebold. I'm a cardiac surgeon from Ulm in Germany. I'm chairing this session together with Mark Bennett, who is an anesthesiologist working in Wales. Mark will take care of your questions, the questions in the chat function, and I would encourage you to take advantage of using this function. I think we have three beautiful presentations or talks. You know, MiECT is a team approach, and the team is composed of the surgeon, the perfusionist, and the anesthesiologist, and all these three components are addressing their specific problems now in this session. I think we are hearing all the presentations before, and then we have a common discussion afterwards. So we have a little time to collect your questions that might come over the chat function. So the first speaker will be Ashraf El. Dear viewers, thank you for staying with us. We had a technical problem to solve, so this break was due to technical issues, but now we are live. We are back live. Ashraf, sorry for interrupting you. Please go ahead with your presentation.
No problem. Well, what I tried to work out in my presentation was that optimizing patient outcome goes beyond excellence in surgical technique. At that point, it becomes a team approach, needing both optimum interaction at team level, but also at human-machine interface. Putting that in mind, knowledge of the common goals as well as the quality of the communication is essential. However, the surgeon is the gatekeeper. He is the one who is exposing the Achilles heel of MiECT. So he's the one who's letting air into the system. He's the one letting the blood out of the patient. I've tried to point out a few things that I have adopted and modified throughout my experience with MiECT in order to adapt to the technique, and that's the main issue. Once you adapt the technique and you adopt new methods of dealing with these problems, you will achieve with your team an optimum outcome that goes beyond mathematics of 1 + 1 is 2, but emphasize and will preserve homeostasis, which is the essence of minimal invasiveness. And as was pointed out earlier, we are facing new challenges, sicker patients, and either we will seek an improvement in our techniques and in our results in order to keep those patients and offer them a solution, or else we'll have to clear the field for interventionists, which have their own solutions. I've tried to point that out in comparing the results of MiECT, AVR, we're using a MiECT in a TAVR population, putting to mind that there was no comparison ever between SAVR and TAVR using a MiECT, so there was always the use of a worse machine and try to show that this can improve our outcome. So we missed on that opportunity once, and we should not miss on it in the future. That's it.
Excellent. Okay. Thank you very much. Professor Argyriadou, Helena, thank you very much for joining us. I wonder if you could also, just in a sentence or two, say what were the main points that you wanted to raise in your talk.
Hello, everyone. Thank you very much. Just a brief comment. MIECT is not considered to be just a circuit, but a technology which prioritizes teamwork for obtaining the maximum gain, as well as for avoiding trouble and adverse outcome from its use. Anesthesia involvement includes several aspects that I have highlighted in my presentation. To sum it all up, the key point in knowing how to use MIECT is to understand the technology behind it and adjust anesthesia technique to the needs and specific features of MIECT. The MIECT approach includes administration of fluids and drugs together with a respective strategy, using patient positioning for preload optimization, limiting fluids and diuretics, selective vasoactive drug use, application of the appropriate monitoring and POC coagulation monitoring, as well as heparin and protamine titration, I think are crucial parameters for the anesthetic management. In the end, what MIECT requires in order to maximize its effectiveness and to improve the patient care is a thorough strategy together with a collective contribution from everyone in the operation room. Thank you.
Thank you very much.
Thank you, Helena, for this nice talk and good thoughts. We can discuss this later. So the third component, and probably most important component of the team in MIECT is the perfusionist. And the third speaker in this session is now Cyril Serek, who is working as a perfusionist in Toronto. And he is, by the way, the president-elect of this society. So Cyril, please concentrate on safe perfusion.
Thank you for the introduction. You know, I think the biggest thing, and I mean, I've been doing mini bypass since 2004. And in the early stages, I mean, basically people were using ECMO devices for mini bypass. So there were basically no safety margins. I mean, the safety margin was the actual perfusionist. And I think it became, or the actual safety device was a perfusionist. And I think we've evolved over time, and we put, you know, venous bubble traps with automatic air purge control systems. We have reservoir, type 4 reservoir with we're able to bail out. So I think, you know, I think safety, I mean, this is the safest operation from a perfusion standpoint that you can get. I think the other thing that we have to realize is that in the old days, if I may say, you know, we were trying to adapt technology that was developed for conventional cardiopulmonary bypass. So we were taking, you know, tubings and using heart-lung machines that weren't really developed for MIECT. And so, but now, you know, we have all the heart-lung machines now are being developed and being programmed with MIECT specifically in mind. So with that, we do have, you know, 100 times more safety. So, you know, and then to the third point, I think we quickly realized that, you know, this is still more than ever, this is a team effort, right? And you have to work together as a team. So us as perfusionists, knowing exactly what you as the surgeons and you as the anesthetists are doing, you know, really goes a long way. So communication is very important. Are you lifting the heart? Is there bleeding? Is there, are pressures being used during the case? So all these things have a direct effect on the patient, on how we interact with each other, and basically the whole safety environment for the patient. Thank you.
Thank you very much. Well, Ashraf, Helena, and Cyril, thank you very much for the brief introduction for anyone who hasn't seen your talks. And to them, I would urge them to watch all three, because taken together, you clearly demonstrate the finesse and the ease with which you approach this technology. And it shows what a synergy it is and can be. But perhaps I could ask each of you, might come back in this in turn, what do you think might be the key things to start a new program that you would be thinking about? Ashraf?
Well, it's what you pointed out at the beginning. You had a comment to my presentation, which was, if we do not see the need to improve more, and we do not know our results, maybe we'll not seek improvement anymore. And that's the point. If you're satisfied with the surgical technique, you're doing the most complicated surgery, and you reach the plateau, well, no improvement, you cannot achieve more, leaps anymore in quality. So you have to adopt new techniques, new possibilities, seek new possibilities. And you have to realize that it's not only the surgical technique, because quite frankly, when we had our first meeting, Professor Angelini asked us as an expert round, do you think that MIECT is better in your hands just because you are the better teams? And I told him, I don't know how I could influence getting off bypass in sinus rhythm every single time. Because before adopting MIECT, we always had a defibrillator pedals on our table, and we use it in more than 50% of cases. Since we started doing MIECT extensively, we're doing this quite seldomly nowadays. So it's not only a surgical technique. And once you see that, it has an influence on atrial fibrillation, well, I don't want to do arterial revascularization in someone who's 50 years old, has little symptoms, but a significant stenosis of his left main, and then send him home with an atrial fibrillation. And this is a loss of quality. And I don't want to send him home with 2 packs of red blood cells that could have an effect on his future.
But you will only know that, the point you're making is you will only know that if you collect the data about your patients and wonder what you could do better. I think it's an excellent point. So, Helena, how do you persuade your anesthesiology colleagues to buy into this technology and to make the effort to fully understand it, which is what is crucial for them to be a part of the team?
I think MIECT is a valuable tool to perform fast track. Those patients are very good candidates to fast track management because they are warm. The use of inotropes are minimum. 74 of our patients are transfusion free, and most of the patients are neurologically intact, and we can extubate the patients hours after operations, 3 to 4 hours after operations. The patient can be weaned from mechanical ventilation. I think those major advantages that this technique offers are obvious post-operatively in the ICU, and it is the most important benefit that we can offer to our patients.
Thank you very much. And Cyril, finally, would you persuade the perfusion colleague in the room next door to try out a type 2 circuit one day? Or would you say to him, let's try out a type 4 circuit where you don't cut in the reservoir? Where do you think is the entry point now with all the technologies that are available to try to persuade your perfusion colleagues to start a program?
I think that's a very good point. I think we really have to demystify, if you will, MIECT. you know, we're all afraid of the unknown, and I think you know, if we don't know what's going on, or if we don't understand what's going on, then I think, and we feel that, you know, things are unsafe, then we'll be very hesitant to use it. So, yeah, I think for a type 4 system, it's probably the best system for somebody to start off with, where they can easily bail out and go back basically to conventional cardiopulmonary bypass until, again, you know, until they're comfortable with what's going on during the surgery. I think and once you go to a type 4, then you can head to a type 3. Type 1 and type 2, I don't think are really great for the OR. I think that it's best to stay with a type 4 or a type 3. But I think the other thing that you have to do is just take small steps as well. Like, you know, if you're like, you just can't jump into this and say, okay, I'm going to use, you know, do all the MiECT concepts right away. Like start off slow. If you're not using cell savers to collect you know, collect shed blood, start using that during conventional bypass, right? If you're not using centrifugal pumps, start using that. So introduce all these things slowly and build up to a MiECT system.
Thank you very much. Andreas, do you want to come back with any comments on that?
There's a question actually coming from Adrian Bauer from COSBIC. It's to Helena. As you have implemented the MiECT to almost all of your patients, is there an immediate effect that you can see in comparison to standard patients? Means, did you implement it in a fast track concept for those patients? Can they be extubated earlier or something like that? Can you elaborate a little bit on that?
As I've already mentioned before, we can win very fast those patients for mechanical ventilation, and they are neurologically intact. And for me, the major benefit of the complete avoidance of transfusion is obvious in the post-operative period.
So will your patients need intensive care stay, or are they going directly to an immediate care ward, for instance?
No, they need intensive care, but they can be, the majority of our patients are extubated 3 or 4 hours post-operatively, and the use of inotropes are minimum, and they have a very clear head, neurologically intact. This is a major benefit.
Okay, thank you. I have another question to Ashraf. I think there's another disruption going on in our community concerning the patients needing valvular surgery or open heart surgery. It means minimal invasive and even endoscopic procedures. How can you combine the advantages of MiECT with those mini access surgery? Do you have experiences with that?
Well, I've done minimal invasive aortic valve surgery quite often with a mini bypass, but mitral valve, let's say in 50% of cases. When I'm sure from the start what the plan is and I know what the pathology is and how I will approach it, I'm relatively sure of the result. The point is, one of the drawbacks of minimal invasive approach anatomically is that most probably you will need more pump time. So it is obvious if you will need more pump time, you have to compensate that in some way. And the best way of compensating is obviously be through a mini invasive extracorporeal circulation. And I think this is the way to go to into the future, and it will be adopted more and more by other colleagues.
When you say you perform roughly 50% of your mitrals with MiECT, what is the criteria? What is the selection criteria?
No, it is rather being sure what the surgical approach will be, how I will deal with the valve. If I'm not sure what if it's a P3 P2 prolapse, if I'm not sure how I will deal with the pathology, if the anatomy of the patient will be quite a challenge, if the surgical challenge is too great, I go for safety because I'm too concentrated on myself.
Okay.
But that is a problem of maybe in 1 or 2 years' times, when I have done more minimal invasive mitral surgery, I will be more comfortable with the surgical technique, and then I will eagerly do everything with me.
Okay.
So Cyril, you made a really interesting point then about taking small steps. And I think, you know, there's a key paper here about how to make those small steps. But what do you think is would there be an impact on simulation training? And has that been introduced, as far as you know, in any countries, so that people can take those small steps with a big margin of safety?
Yes, well, simulations are basically still in its infancy, and I think not a lot of people have good access to it. But you know, we have a simulator ourselves where we just done that training on the MiECT system, especially when you're looking at going over emergency procedures, you know, massive air, etc., which you would do for a conventional cardiopulmonary bypass as well. So not necessarily just a MiECT system. Yeah, there are places that you can go. Like if you're really interested, you can get a team together, and I think Medtronic has a facility that you can go and do some training on simulations on MiECT. That's one thing we're going to develop as part of our society, is looking at a lot of training centers and simulation centers, try to increase those across the globe, just dedicated for MiECT.
Thank you very much. I don't know if we've got any time for one last question. No, we very unfortunately are out of time. But maybe I can thank from Andreas and myself, Ashraf, Helena, and Cyril for your presentations, as we've said, which are available to view, and for your comments today. So thank you very much.
Thank you.
Thank you.
Well, hello again. Welcome, everyone. It's my great privilege, actually, to be co-chairing this session with Professor Cam Incha. And I think this session, to me, is perhaps one of the most fundamental as we talk about reasons to have a change in our approach into using MiECT systems, because really it's at the microcirculation where we begin to see some of these potential benefits that, as we've pointed out, translate into a variety of optimized clinical outcomes. So perhaps as we get started, we could start with Professor Gunajan talking about molecular evidence of MiECT on clinical outcomes. And I'm particularly interested now to hear your comments, because I think this is a particularly fascinating aspect of your investigations. If Professor Gunajan is available. In which case, perhaps we'll go on to Mike O'Neill. Mike is a perfusionist at London Health Sciences Centre. Mike has done some really fascinating work on looking directly at the microcirculation. And I'd like to hear your just a brief synopsis, Mike, of your investigations and what some of your conclusions are from your investigations to date.
Hello, everybody. Thanks, John. My name's Mike. Yeah, so I've been putting a lot of work into a research project on the microcirculation. What I think needs to be done, especially when we implement these new types of strategies to attenuate the systemic inflammatory response, we also we need to be able to have better guidelines for diagnostic therapeutic interventions, so that we can actually not only just look at our outcomes, but have something to guide us along the way. And in terms of the microcirculation, normally what we do is we put the cart before the horse. We monitor the macro hemodynamics. And I think it's maybe time that we put the horse before the cart and take a better look at the microcirculation, because as we know, this is where pathophysiological insults occur. And by the time they reach the macrocirculation, the damage has already been done. So in our lab, we designed a NIRS device in which we could track the microcirculation in terms of the total hemoglobin content at the isospastic wavelength. So, and what we've seen so far is, and this was a feasibility study, not so much in the design and build of the device, because anybody can do that. It's the feasibility of the algorithm program in order to interrogate that data coming back from back to the spectrometer. So when we did this, we concentrated on just four major time points: initiation of bypass, aortic cross-clamping, cross-clamp removal, and termination of bypass. So we found some interesting things along the way in terms of what occurred during mechanical ventilation and the effects of the total hemoglobin content changes associated with positive pressure ventilation and decreased venous return. So that was exciting. And that just kind of gave us a lot more encouragement to continue on. And, we've seen some interesting things happening with phenylephrine bolusing, which perhaps maybe that could lead to a discussion of continuous infusion versus phenylephrine bolusing, and hemodilution. And we also broke the signal down in order to see exactly where, with continuous wavelet transform, what type of oscillations are being incurred within that signal at different band levels within the microvasculature. And we were able to see, cardiac heart rate in the ventilator and some of the phenylephrine spikes along the way as well. So some interesting work and a lot of work ahead of us. So yeah, this is just work in progress, and I'm happy to talk about any questions you have for me. Thank you.
Perhaps what we'll do, Mike, is just hold that for a second. And I think particularly having looked at some of the abstracts, I think Mark Bennett may have some comments regarding phenylephrine and interacting with your results on the microcirculation. But I think Professor Gunyadin is now available, and perhaps he'd like to give us just his quick overview of his findings regarding the impact of MiECT on the microcirculation, the glycocalyx, and some of these fascinating mediators.
Thank you very much. It's very good to be here. And regarding microcirculation and the cellular impact of the MiECT systems, we did a series of studies in the lab or also in the clinical setting. So we used to work on the cellular response of the cardioplegic solutions, especially single dose cardioplegic solutions before. So we have a kind of experience in that. So in that setting with the single dose cardioplegic techniques, we worked to understand the effects of hemodilution, because large doses are administered to the patient in single dose techniques. So in this sense, we just carried the same setting in the MiECT in the OR to understand if the hemodilution can give us some clues as a very preliminary phase of the inflammation or cellular disruption or source of the conventional system. So we worked, we compared MiECT with the conventional system, and we checked for the clinical end products of the Glycocalyx degradation, synthetone 1 levels. And also we work on the aquaporin levels. Aquaporins are the molecules that are secreted with response to the overvolume of the cell, to fight with the overvolume of the cell. So a healthy cell can produce enough amount of aquaporins to overcome that. So we checked the endpoint of the aquaporin levels as a PCR. And also we have some samples from the ventricle to work in the lab to check for the microscopic outcome. So why did we do this? Because we did a series of clinical comparisons in between conventional circuits and MiECT, and it's not easy to find any clinical difference, significant difference, with limited number of patient populations. So we work at most 100 patients in each group, and we couldn't find any early significant differences. And then we worked only on high-risk patients, and we couldn't demonstrate a clear significant difference in between two groups. So that's why we just take this cellular model that we used before to understand the best preliminary, very, very early response of the cellular level to these different type of settings. So we really get some very good results. And we understand that with even in the cabbage patients, when we compare MiECT with the conventional system, so the synthetone 1 levels were very high. There's a higher, significantly higher in the conventional group that demonstrates as a cellular damage, the early sign. And also the aquaporin, let's say, competence of the MiECT systems were much better than the conventional system that verifies us to ability to fight with the hemodilution. So this is, of course, a very early stage of study, but can give us an idea to set up for larger studies in the near future.
Could you just make a quick comment about fascinated with the impact of microgaseous emboli, hemodilution, the role of heparin in preserving or disrupting glycocalyx, and I noticed that one of your presentations had some data on that.
Yes, so glycocalyx is a very sugar coating on the endothelium. It's a very thin coating, but it goes back up to the first living creatures in the world. So it's the earliest sign of the cellular layer that's demonstrated in studies. So it's the first response of the cell to anything abnormal in the ongoing status, like inflammatory response, volume overload, or hyperglycemia, or anything else. So it's the most sensitive parameter to be understand that there's something going wrong within the cell. But of course, it's not easy to understand or specify the correct problem. So I believe it should give us an idea, but should be verified with something else to understand the real problem ongoing. It's sensitive to many different pathologies regarding to the cell function.
Good, thank you very much. I think now perhaps I'm very pleased.
Can I ask a question?
Oh, absolutely. Carry on, Ken.
So I think in this session, we'll see the word glycocalyx coming back several times. And even though I believe that MIECT can have a very large benefit, there are, of course, many other conditions which can alter the glycocalyx. And by altering the glycocalyx, everything we're going to talk in this session is going to alter also pulsatility, non-pulsatility, inflammation, leukocyte adhesion, thrombogenicity, etc. So my question to you, Professor Günaydın, is the following. Besides the MIECT, are there any other conditions during cardiac surgery which you think could be protective for the glycocalyx? And I'm thinking about the priming solutions. I'm thinking about the type of anesthesia, maybe. Have you thought at all about this aspect?
Yes, sir, of course. As I've told, the glycocalyx degradation is not a specific sign for any single disorder. So it may be a result of anything or in combination of different parameters during the ongoing surgery. So we did series of studies for comparing of single-dose cardioplegic techniques, and we understand even the type of cardioplegia may have some kind of glycocalyx degradation. And also we compared some different types of priming solutions, including albumin or corticosteroids or whatever. So even it changes the glycocalyx degradation in the early phase. So there may be a lot of parameters in the OR that may change the glycocalyx response.
Okay, if I may have a question to Dr. O'Neill too, Professor Merkin, is that possible, a short one?
Absolutely, that's the whole point here.
Okay, so thank you very much for your presentation, which I watched online, and I must declare interest here. I'm a skeptic when it comes to near-infrared spectroscopy, so that's why I would like to ask you a bit more detail. We've been doing a lot of studies now in COVID. I'm sure a lot of you have been doing that. And what we see, and we published this in Critical Care Medicine a couple of months ago, looking at the microcirculation in COVID, is that you see a movement of capillary hematocrit or systemic hematocrit to the capillaries. It is as if the body compensates for the hypoxemia by recruiting red blood cells specifically in the capillaries. It's very interesting because it's similar to climbing a very high mountain like the Everest. So my question to you is this. Your focus has been on the brain, and what we really see in a lot of the studies is that there is a heterogeneity when it comes to the oxygenation of the various organ systems. And might it be so that by protecting the brain, you're offering up, for example, the kidney or anything like that? So do you have any insight into what's going on with other organs beside the brain?
Yeah, that's a good question. So we're actually looking at the skeletal muscle on the thigh. So we haven't placed any probes on the brain in terms of our study at this point. Hopefully down the road, we're able to do that and see if there's any type of redistribution occurring from skeletal muscle to the major organs. But you're right, are we sacrificing, kidney perfusion for brain perfusion? So that's a good question, and I don't know the answer to that. I mean, the only thing you can do is maybe if you had the ability to place a probe, but we know that's not an option in adult population, but perhaps in neonatal, where the light can be absorbed a lot easier. So honestly, I'm not sure, but you're right. You're right by making that statement.
If I maybe could give this is something I would have always liked to do, but I don't have this technology. But if you happen to have surgical patients who've had kidney transplantations, their kidneys are going to be pretty on the surface of their skin. And my idea would be that in patients with kidney transplantation, should be possible to get a near signal by placing it on that surface. It's just an idea.
Right.
I think that's a really good suggestion, Akam, about looking at the kidneys. Certainly in pediatrics, there's been some reasonably compelling data using NIRS that one can detect signals and changes in renal perfusion. I'd just like to backtrack a little bit. Your comment about sacrificing the kidneys to save the brain, that assumes you got a one-trick pony, which is just to vasoconstrict the patient. In point of fact, as we published a number of years ago, there's a number of strategies of which providing vasopressors is probably about the fourth or fifth down the list, starting with appropriate management of carbon dioxide levels, the alpha-stat hypothesis, which we know optimizes end organ perfusion throughout the body. Secondly, we're talking about cardiac output, hemoglobin concentration, et cetera, et cetera. So yes, it is theoretically possible if one is just pouring in vasoconstrictors as a first approach when you see a brain desaturation. But I would actually say that in point of fact, there's a much more physiologic strategy that can be employed. And perhaps at this point, it'd be a nice opportunity to bring in Akif Undar. And I'm very, very pleased that Akif was able to join us. He's going to be talking about pulsatile perfusion, which has been a particular interest of mine going back several decades. So perhaps, Keith, if you'd like to just share some of your primary considerations with us, and we can carry on with the discussion.
Sure. Thank you so much, John, and thank you so much for the organizing committee for the opportunity. For overall pulsatile flow, I have to say this first. Pulsatile flow is not a magic bullet. It does not eliminate the adverse effects of cardiopulmonary bypass procedures. I mean, there is a myth that if a person can use a pulsatile flow, then all of a sudden ICU times, ICU duration, lactate levels will go down. I mean, those are really myths. If you look at the overall picture of pulsatility, pulsatility can only minimize the injury, vital organ injury. The reason that I'm saying it, we have done over 300 piglet experiments, and we have done several clinical trials, and we just finished up a randomized clinical trial. But all of my personal experience with pulsatile flow in pediatric models and the pediatric patients, we do not do anything that the adults here at the Children's Hospital. So what we found out that the most important is actually the pulsatile pump. So some of those pulsatile pumps cannot generate pulsatile energy at all. And some of them actually do generate energy, but they create significant amount of hemolysis. So that's why, I mean, 75% of the hemodynamic energy generated by the pump absorbed by the oxygenator, length of the tubing, and arterial cannula. So in order to achieve any good quality pulsatility, we have to optimize every single component. In particular, the cannula is the smallest one. Even the cannula's geometry has a huge impact on the quality of pulsatility. When we achieve adequate quality of pulsatility, by the way, we quantify the pulsatile energy in terms of surplus hemodynamic energy and energy equivalent pressure formulas. When we have that physiological quality, then we can clearly see vital organ injury, brain, kidneys, and heart, perfusion significantly better under pulsatile flow conditions compared to non-pulsatile. And we did use near infrared. We, of course, use transcranial Doppler. We have a neuro monitoring team. Here that for every single bypass case, actually, we have NIRS, EDAC, as well as that the transcranial Doppler and EEG for every single patient to monitor them completely. So, and the other thing about the pulsatile flow, actually, whoever uses it, they must use a transcranial Doppler to make sure that first, they have the pulsatile energy in the brain. On second, there are no additional microemboli delivered to patients. So that's the only way we can actually see it with the transcranial Doppler. So overall, again, that the pulsatile flow is not a magic bullet, but it can minimize the injury. Thank you.
Thanks so much, Keith. And again, I can reiterate those comments. We made an interesting observation using transcranial Doppler that when we institute pulsatile flow, we immediately hear the pulse oximeter on one of the digits start to pulse. So if one doesn't have the ready availability, or you can't get a window for TCD, if you're getting a pulsatile, good pulsatile signal from your peripheral pulse oximeter, it probably is strongly suggestive that the brain and other organs are in fact seeing a pulsatility. And perhaps on that note, we can just have Professor Honecker talk about MIC and.
Could I just ask a question?
Yes.
Before you go on, yes. So thank you very much, Indar, for your Professor Indar, for your talk. I've done a lot of research on pulsatility. And as a physiologist, this is my perception of why pulsatility could be beneficial. Please correct me if I'm wrong. So my idea is that the pulsatility affects the mechanotransduction in the glycocalyx and causes nitric oxide to be released from endothelial cell nitric oxide synthase, improving the vasoactive component of perfusion. Now, if that is the mechanism of why pulsatility, by moving shear stress up and down, then it would seem to me that MiECT would have an additional advantage over conventional CPB because we know that additional fluids cause a destruction of the glycocalyx, and the signal transduction which you would require for pulsatility to be effective is absent in hemodiluted patients, which would be much less the case in MiECT patients. What do you think of this idea?
Is it a question for me?
Yes.
I'm sorry. For capillary perfusion, that the microcirculation, that the only way we hypothesize, I do not have the intravital microscope like you have, and we have actually followed all of your publications about microcirculation. So in capillary level, the only reason that we are seeing significant shunting under non-pulsatile flow, even though we have identical pump flow rate, organ blood flow in the capillary level significantly decrease under non-pulsatile compared to the pulsatile perfusion. I think this may be one of the, the way that I can explain, but that is actually the theory we adapted it from Dr. Ken Taylor from years ago. He did publish the book called Cardiopulmonary Bypass. Ken Taylor.
Is there a difference between the venous saturation between pulsatility and non-pulsatility?
Venous saturation, I do not have much experience. I don't have the data to share. I'm sorry.
Thank you.
Professor Indar, while we've got a couple of questions from the audience. Sure. One is of interest. Do you have any evidence that pulsatile perfusion sandblasts or otherwise is disruptive, particularly in the presence of an atherosclerotic aorta? I know this has been an underlying concern from a number of clinicians. So do you think pulsatility can potentially adversely impact the aorta in atherosclerotic patients or others, I guess?
And the other thing that I didn't mention, of course, that how we actually designed the pulsatile module that is for the roller pumps that is quite different than the rotary blood pump systems. But to make the answer short, yes, I do believe that the Pulsatility, because it's going to be more energy and pushing through that surfaces, and it may actually take some of the particulate emboli to the patient's brain. But what I was going to say, I don't want to, I'm looking at the timing here, so I'm a little bit worried. we have two other people in the committees. One of them is you, so I don't want to take too much of their time, but if I have time, I'll be happy to, to give you more response how we create pulsatile flow in roller pump system versus rotary blood pump systems.
Yeah. I think just in the interest of time, we do want to get Professor Honica to talk about are we pulsatile enough, keeping on with the same theme, and then maybe we can circle back to some of the other questions.
Okay, hi, this is Marcus speaking from Ulm. I just want to give a very brief overview over what we did. We actually started with a clinical trial looking at the differences between pulsatile and non-pulsatile MiECT. And I was involved as a scientist, essentially just evaluating the biomarkers initially. But I got hooked into the topic because I was really surprised that we did not find that many differences. We did have decent differences in clinical outputs, but essentially most of the markers did not respond to pulsatile flow. And this was essentially the starting point to look into this in depth and take the system apart, take it back to a perfusion model. This is what scientists like to do, to move back to models. And while analyzing all the components and their contributions to pulsatile energy, our main finding was that pulsatility is fairly limited at the high flow rates that we need in adult surgery. So we found there's an optimum in terms of hemodynamic energy around 1.5 liters per minute, which makes every pediatric surgeon happy, but is far off the optimum that you actually need in adult surgery. So we checked all the components, oxygenators, tubings, cannula, and there were essentially no surprises. Similar results as Akif Undar got for his pediatric patients. And the only real difference that we could make in our model is to use two pumps, DP3 pumps in parallel, because we understood that the pump was actually limiting the amount of energy that we could put into our pseudo patient. And we did a couple of configurations, and this was essentially the only thing that we could really improve. Improve the settings of the console and use two pumps in parallel. And in the final step, we actually moved to a completely different type of pump. It's an occlusive pump, so you couldn't readily use it in any patient in a MiECT system. This was simply to confirm what happens if we have a pump in our model that has a sufficient amount of hemodynamic energy during pulsatility. And this actually showed that at least up to 3 liters, this engine didn't create higher flow than 3 liters. We can generate really huge amounts of hemodynamic energy. And our conclusion was basically, while we certainly have to optimize everything between the pump and the patient, which we already did, we simply have to look into different types of pulsatile pumps in order to get the type of quality of pulsatility that we need in adult surgery.
Well,
thank you.
Yes, and thank you very much for those comments. And perhaps I had a few comments to make about brain monitoring, which one can see online. But just complete this discussion about pulsatility, I was very struck a number of years ago when we were measuring cerebral blood flow using xenon washout techniques, measuring cerebral metabolic rate. And along with our observations that with the conventional roller pumps, we were very effective in producing a pulsatile waveform that we could detect on transcranial Doppler and also the pulse oximeter, that what we found was with the institution of effective pulsatile cardiopulmonary bypass, and I understand effective is almost a philosophical construct, but effective bypass that we can see a pulsatile waveform in the MCA artery resulted in not only an increase in cerebral blood flow, but most interestingly, a small increase in metabolic rate. So I think this whole concept of pulsatility and its role in perhaps some of the more challenging patients where microcirculatory impairment as a consequence of diabetes, et cetera, may be playing a role that I think we have a lot more work to be done with the potential impact of the role of pulsatility and particularly if we combine it with the mini bypass circuit. So sorry, everyone. I think in the interest of time, we'll have to move on to the next session. But thank you all to all the speakers, and I think we've had some interesting comments.
Thank you.
Hello, everybody, again to the session number 4, which is on awareness of MIECTS. And we have some interesting discussions. We are discussing how MIECTS can cooperate with ISMICS, how MIECTS can cooperate with the European Anesthesiology Organization, and we'll start with having some comments from the EBCP. And Philippe de Soma, he is the chairman of the European Board of Cardiovascular Perfusion, and I would like to ask him to comment on the topic of awareness. What can we do to make people more aware of MIECTS?
Thank you, Alexander, for your introduction. As European Board, we are very interested in getting sufficient knowledge. And it was stressed, I think, by every speaker that if you want to perform MIECT, then you have to have a good collaboration between all the different specialties available. Now, one of the major interests of the board is to increase the education level, to be sure that people are recertifying and that we can fall back on fully accredited schools. And in that way, we believe that it's very important that if perfusionists want to use MIECT, that they can do that in a school, or that they can have a training in a school, which actually has teaching people who are aware of that. For example, if I take Belgium, we have 2 schools, and Pascal, who is part of the faculty here, is one of the persons who is actually teaching this to new students. I think it's very important for us that we can give accreditation to schools and see how this training is done. Also, the fact of simulation, it was already mentioned. I think it's a very important issue. The board is supporting this, and we try to help people to set up good trainings in their different schools. A part of that, as a board, we also want to diffuse the information in a broader area of perfusion, meaning that we actually give the possibility for national societies to use the Zoom platform in order to, for example, invite people like the ones here present in the faculty to present their latest data and to make people aware of the advantages and eventually potential problems when they start using MIECT. So that's in a nutshell what the EBCP wants to do, and I think a lot of these goals are also similar for MIECTS. So I think we are in a certain way natural partners.
Thank you very much, Philippe. I would at the same point of time introduce my co-chairman, Adrian Bauer. And would you like to comment on what Philippe just said? What is the situation in Germany with exposing young perfusionists to the method of MIECTS?
Yeah, thank you, Alexander. Also, thank you to the organization here for congratulations for that congress online. Yeah, I can only emphasize what Philippe is also saying. We have to start very early with our students to make them aware of the possibilities to treat the patients in a more safer and a more minimal invasive way. And what we are doing is we have it in the curricula of the schools already. We are doing MIECT education at the academy in Berlin and also in the other universities. And one thing could be, and that should be considered and that should be planned also in the at the European board, to make MIECT part of the syllabus of the European board education. So then we can also ask during the site visits when we go to the schools, we could ask and for that education and for that part of perfusion. So that could be one way. And Philippe, I think that could be one thing what we write down on our agenda for the next meeting, probably.
Adrian, you have a lot of experience of how the situation has changed in recent years. So obviously most students of perfusion, they know about MIECTS, but do you think that the younger people, they have a stronger interest, and are they all sort of being exposed to MIECTS in recent years?
Yes, I do. but they are the youngest people in the team, and they want to do it, but they have to. They need time, and we need time for the technology. And I have requests also for my clinic for hospitation that they come to us and look what we are doing with MiECT, but it needs time. Yeah, but the awareness is already there, but 5 years is nothing.
Thank you. Philip, I know that EBCP has started a new line of webinars where we focus on countries to show what the different countries are doing. And you mentioned that in your video, but there's also focus on specific topics, and maybe minimally invasive extracorporeal circulation should be a topic for one of the Eurofusion meetings. What do you think?
I can only agree with that, but the basic idea of Eurofusion is, of course, a little bit different in that way that Europe is a large area. And what we wanted to do with Eurofusion was that people would learn to know each other a little bit better. What do I mean by that? Now we know that there is, for example, a Dutch society, but what are the particular interests, the particular training measures in Holland? The same will be true for Germany, for Norway, and for other countries. So the main issue was to make these national societies better known in the other countries. But of course, beside Eurofusion, we also have specific webinars. And one of them, for example, was the latest one was prime time. So we actually focused on priming, but it could be as well be MiECT and what are the best things to perform MiECT. So I fully agree. This could be part of one of the forthcoming webinars of EBCP.
Thank you. Maybe we should just for a few minutes focus on the cooperation with our colleagues from Anesthesia. And there we have a short message from Gabor that we could play in because unfortunately he couldn't be with us today. Is it possible to play his short video?
Well, on behalf of Anesthesia, I'm happy to make a few comments. I think Mark also has some points to make, but I think, yes, I think a general awareness is what we're really talking about. As we all know, anesthesia can't drive the bus. By definition, our role is to stabilize the patient and support the surgical procedure. So the ultimate initiative is that combination between surgery and perfusion to decide that this is the approach that's going to be taken. And the role of anesthesia is to facilitate that. I also think that part of that, however, is to raise the general level of awareness so that if the cardiac anesthesiologists are more aware of not only the technique and the approach, but some of the potential benefits, as we heard from Professor Punjabi at the start, the fact that the lower priming volume, the less inflammation in particular patients can be of very particular benefit. So this becomes a solution, but of course one has to be aware of this whole strategy in order to recommend and undertake this as a solution for the problems that have arisen. So I think on the anesthesia standpoint, it's really a question of becoming somewhat familiar with the techniques that one's using, but also to try to encourage one's clinical colleagues that this is an important approach that really does need to be looked at very carefully and hopefully initiate a program.
May I add something to that? I think it's very important that for that reason there is close collaboration between different societies. Because like you mentioned, sometimes you see that people are using MiECT, but the anesthesiologist is pouring in fluids while doing induction. And then, of course, part of the benefit is lost. So I can only agree with you that it's very important that we have close collaborations like MiECTS, where we have the different specialities together and that we discuss these issues.
Philippe, I think that's a tremendous comment. And, you know, it takes me back to the early days of beating heart surgery. And in some centers, that was the standard of care for anesthesists, is if the pressure goes down, just dump a lot of fluid in. And it took a lot of education to really point out that this is really suboptimal for a whole number of reasons, and that really more judicious use of inotropes, vasopressors, and these vasoactive agents, as well as simple table tilting, and it's the integration of all of these factors. And as we keep talking about, this is really a team sport. And so, yes, it does certainly behoove anesthesia to become aware of what the other management strategies are, and how all of these various approaches summate to produce a successful use of the MIECT system.
Yeah, and just to add something, it's very important that we be aware that if we talk about synergies, then we have to talk also about 2 points. First is the synergies in the daily clinical routine, to be aware of volume management, to have the norepinephrine with you, and so on. And second, the collaboration at the scientific level. Firstly, we are the benefits from the joint work. Our patients benefit directly. So, for example, and as mentioned earlier, from a fast track concept, with, for example, an ultiva anesthesia, or in relation to surgery, to less frequent atrial fibrillation, that's in our hand, and we must bring that out, that advantages from MIECT together. So, but we can also achieve a lot in cooperation with the scientific societies. We should have delegates, and we should have always a MIECTS expert as part of the groups making the recommendations, making the guidelines in which cardiopulmonary bypass plays a role. So that's also important. These both things must be stick together, I think. So I guess now we have the film. We can see the film from the anesthesia. Is that right? Or is it then the next video from Professor Edwards to the pre-recorded film? Is that the right one? Yeah. So we can start it now.
Good morning, ladies and gentlemen. My name is Gabo Erdős. I'm from the University Hospital of Bern, Switzerland. I would like to provide you a short overview about the possible connections between MIECTS and EACTA, which is the European Association of Cardiothoracic Anesthesiology. You see here, EACTA and MIECTS are already connected with each other directly, but also indirectly through various other professional societies. This is due to the fact that the clinical and scientific areas of interest are closely related. EACTA has been called EACTA-IC for a few months and now represents not only cardiac, thoracic, and vascular anesthesiology, but also the associated intensive care medicine. EACTA has a claim to be the leading European association for professionals working in cardiothoracic and vascular anesthesia, intensive care, and perioperative medicine. In this sense, EACTA would like to be a leader for scientific research and education. It would like to encourage specialization in cardiac, thoracic, and vascular anesthesia and intensive care medicine. Also, EACTA strives, among other goals, to closely cooperate with other societies in matters affecting the aims of the association and its members. In the field of education, EACTA has put together a European fellowship program, the structure of which has recently been published. Basically, the fellowship program includes a basic program part and an advanced program part, each lasting for 1 year. The basic part includes mandatory modules. These are intended to guarantee a solid basic training. In the advanced part, the fellows can take modules according to their interests and thus obtain a different degree. Possible degrees are fellowship in adult cardiothoracic and vascular anesthesia, cardiothoracic anesthesia, cardiac anesthesia, cardiac and vascular anesthesia, thoracic and vascular anesthesia. There are overlaps with MIECTS in each module. For example, EACTA has an extracorporeal perfusion management module, which intends to teach relevant knowledge in extracorporeal perfusion techniques, also including different types of extracorporeal circuits, cardioplegic solutions, and management of complications. EACTA has different subcommittees. One of those is the Cardiopulmonary Bypass Committee, with the aim to develop guidelines and promote education. Here you see the composition of the Cardiopulmonary Bypass Committee. I think a closer cooperation between EACTA and MIECTS would be very useful. Possible perspectives could include the following points: collaboration in drafting guidelines and recommendations, and involvement of MIECTS members in EACTA subcommittees and vice versa, a joint organization of webinars and congresses, presents in cardiac anesthesia related activities, congresses, journals for a better visibility in the community, a joint finding of research grants, and also finding of travel grants and visiting professorships. Thank you very much for your interest.
Okay, Professor Bennett, would you like to comment on what Gabor presented to us?
Yes, I think it was an excellent point. I think if we take MIECTS to a level that some people view it as, you won't excite anesthesiologists. But if you expand that, already in this Congress, we visited the microcirculation, the effects on coagulation, the endothelium, extravascular fluid, and the inflammatory response. And whilst many anesthesiologists won't pay an awful lot of attention to those in the OR, they certainly pay a huge degree of attention to those factors when their patient is admitted to the ICU, where they may also be the clinician looking after those patients. And synergies, as was just described, between MIECTS and EACTA with intensive care and ACTAC in the UK are essential and vital, and will be of fundamental interest to all the professionals involved in intensive care. So I completely agree with his statement.
Thank you very much.
I just want to echo that, Mark. I think the involvement of intensive care and again, this strategy, this approach to patients is crucial. And I think one of the differences, however, between North America and Europe, perhaps, is in many circumstances, even the cardiac recovery unit is not necessarily managed by either surgery or anesthesia, but may well involve, in some circumstances, internists. So I think engagement of the critical care societies as a component of this, so that the postoperative care of the patients is integrated into the strategy, is very important.
So, Dr. Waba, can I make a very short comment about the ISMICs?
Yeah, I was just going to introduce you and ask you to comment on that. And I could just give you a question that you could also comment on. And that is, if you do minimally invasive surgery, then this is quite a difficult endeavor for many surgeons, and you have to be very careful with the details. Is it too much to ask to do the same minimal invasive operation with a mini bypass as well? Do you increase the difficulty too much? What is your idea?
Thank you very much. So it's a kind of, we always talk about the teamwork. So what I believe is, as I also do minimally invasive surgery, so we are the surgeons that are looking for something new that's better for our patients. So we go under all of trouble to do something novel and to modify our clinical outcomes. And indeed, from my point of view, it's a way of competing with the cardiologists, interventional cardiologists. So, for example, we published a paper introducing the use of MiECT plus minimally invasive aortic valve surgery compared to the conventional techniques. And we, of course, the number of patients was not very large, but we really demonstrated some kind of significant clinical outcome, better clinical outcomes in this group. So what I believe in the near future, when the cardiologists are doing TAVI or mitral valve replacement or tricuspid valve replacement, we need to modify our results so surgeons are aware of that and started doing minimally invasive techniques. But to go one step further is to add the physiologic bypass to this setting. So this is the MiECT. So in our group, so our perfusionists, anesthesiologists, and surgeons are experienced with MiECT. So we get one step further to introduce and implement the minimally invasive techniques with MiECT together to get much better results.
Yeah, thank you very much. That's very important. And often it's the case that that there's a combination between minimal invasive surgery and maximal invasive perfusion. I often see that you are using, or some clinics using roller pumps and a big heart lung machine for minimal invasive surgery. So, and that's the point. We have to bring that both together. We have to marriage it, and probably we have to found a think tank within the ISMICS or within the MIECTS to bring that two parts together and to bring it forward for our patients.
But before coming here, I reviewed the innovation journal, the journal of ISMICS, and unfortunately only maybe 10% of the papers were focused on cardiopulmonary bypass. So I believe the awareness is not still complete, so we need to work more on these surgeons.
Yeah, you have to give your perfusionists more time to doing research. Okay, fine. Any questions to Professor Gunyadian or to the others regarding awareness of MIECTS? So is that not the case? We can save a little bit time, what we're losing or before. And it was a very interesting session, and it's very, very important. And we cannot often replay it. The teamwork is the most important thing. We have to bring together all the parts. And thank you very much. And I give the word back to you, John. Thank you. And thank you, Alexander, and all the others.
Hello, everybody, and good morning or good afternoon, wherever you are. My name is Dr. Shapira, and I'm a professor of cardiothoracic surgery at Hadassah, the Hebrew University in Jerusalem, Israel. Together with me is Mr. Cyril Sarik, who we're going to co-chair the session of abstract awards. First of all, before we start the session, I want to congratulate Dr. Merkin and Professor Anesthesiadis and all the organizers for organizing a phenomenal meeting that bring together people from all around the world to deal with this very important topic that's needs to be more covered, the minimally invasive extracorporeal technology. I also want to thank the industry for sponsoring such an endeavor, really promoting the awareness of this issue. With that being said, let me introduce the first abstract, which is there are 3 winners in this competition, and the number 3 award is given to Dr. Bennett, Lloyd, Weatherall, and Webb. And the topic of the abstract, number third place, is the influence of vasopressors on venous return during cardiopulmonary bypass with minimally invasive extracorporeal circulation.
Thank you very much. Is the video going to be played?
Yep, I think we're going to play the video now. Here we go.
We need to play the video. We're running out of time.
Good morning, my name's Mark Bennett. I'm a cardiothoracic anaesthetist in Swansea and previously in Plymouth. We have investigated the rate of venous return into a minimized circuit, which is important in the circuit without a reservoir to ensure that the centrifugal pump is able to deliver adequate arterial return back to the patient. The rate of venous return is dependent on both circulating physiology and on fluid dynamics. It contains 70% of the circulating blood volume and is held as both an unstressed volume and a stressed volume, the pressure of within which is referred to as the mean systemic filling pressure. The mean systemic filling pressure, if it is high, as shown on this graph here, results in an almost linear relationship between pump speed and pump flow delivered. However, if the mean systemic filling pressure is low, there is an inflection point, and above a certain pump speed, pump flow doesn't increase any further. Because of these factors, cardiac index, despite the same target flow, is lower with a MIECT circuit, and the flow variability, the range of flow, is also wider with a MIECT circuit. Together with this, the mean negative pressure in the venous line of a MIECT circuit is more negative, and the range of negative pressures can reach quite considerable negative pressures. We investigated whether the venous cannula itself can influence the cardiac index and negative pressures, but found no significant difference whether we used a 2-stage, a 3-stage, or a fenestrated 3-stage cannula. So we hypothesized whether we can increase the mean systemic filling pressure by the use of alpha and beta agonists to improve the rate of venous return, and by doing so augment the arterial inflow back to the patient and reduce negative pressures in the circuit. We compared 16 patients from the venous cannula study where a two-stage cannula had been used. And over a similar time period, we looked at 16 other patients, also with a two-stage cannula, but where by anaesthetist choice, a very low dose of norepinephrine or dopamine had been started prior to CPB. We found that the flow was significantly higher in the pressor group, and because the dilution was the same, the average oxygen delivery was therefore also higher. The mean and median negative pressures were less negative in the pressor group, and the duration of the bypass time, where the pressure was less than minus 60 millimeters of mercury, was also significantly shorter. So in conclusion, we found that a low-dose pressor agent used during cardiopulmonary bypass with a MiECT circuit can significantly improve the flow characteristics of the circuit and increase the oxygen delivery. Thank you very much.
Thank you, Dr. Bennett. Great presentation and a very interesting and clinically useful topic. We used vasopressors in the setting of retrograde autologous priming to maximize the RAP volume that we can get out. It's also somewhat dangerous maneuver. So I have two questions for you. You use two different strategies which are markedly different, whether you use noradrenaline or you use dopamine. I think dopamine is allow you visceral vasodilation, particularly the kidneys, so you can get more reassured that you get better tissue perfusion. So why did you choose one time to use noradrenaline or norepinephrine, and the other patients use dopamine? In my perspective, dopamine is much more safe. And second, so let me stop here with the answer.
Well, the main thing, this wasn't a randomized trial. This was a hypothesis that led us to data search patients who had had a low dose of one form of pressor or another running, both of which we believe can stimulate both the alpha and the beta receptors. It wasn't randomized. This is just a data search from our database. The theory is that a pure alpha agent, phenylephrine or metaraminol, can only increase the alpha effect, which, although that increases the mean systemic filling pressure, also increases the resistance to venous return. Whereas if there is some element of stimulation of the beta receptors, you may not get such a marked increase in resistance to venous return. So there is more blood returning to the pump so that you can achieve a higher cardiac index. And that may be what we were seeing. We would need to do a randomized blinded trial to be able to prove that a little bit more definitively.
Yeah, clearly, that's the flaw of the study. This kind of things which are very interesting to the practicing perfusionists, anesthesiologists, and surgeons, we will need more level 8 data with a prospective randomized trial, because this is markedly different using dopamine at very low dose when the vasopressor effect is actually minimal and it's mostly vasodilatory. So
yeah,
if you got the same effect, it's probably safer to use low dose dopamine rather than alpha stimulant. Any other comments, because we are limited in time for discussion?
Yeah, I'd just like to make a comment. Mark, do you actually run pressors now regularly during MiECT cases, or is it still up to the anesthetists or surgeons?
It's not a unit policy. I will often run them myself, and I just let the perfusionist know that they're running at just a very low dose, so that they can comment back to me if they need me to turn them off or perhaps to increase them. But often a very low dose running through bypass reduces the amount of pure alpha agent that's given. Right. And as long as there's good communication, then you're not going to run into any trouble.
What do you normally start off with?
Just at 0.01, 0.02 of norepi.
I just would comment, obviously there is a need for a prospective randomized trial. On the outcomes, you should also look more carefully into tissue perfusion than just flow rates. And you mentioned in your abstract, but not in your presentation, the lactate level, but that's only a crude parameter of tissue perfusion. But I think there is a need to look in what's going on with tissue perfusion when you do microcirculation and vasoconstriction. That's
Absolutely.
one thing. That's another point that you should look into. Endpoint is to look into blood element destruction. Clearly, one of the most important beneficial effect of this strategy will be that you have less negative pressure. Negative pressure is a known inducer of element destruction, like platelet destruction and hemolysis and so on. So just kind of for future studies. I think for the interest of time, we need to move forward because we have very limited time. So I apologize. This is a very, very interesting topic. Thank you for the presentation. And I'll move to Cyril to present the second award, please.
Yeah, the second award goes to Drs. Beretta, Galizia, et al. Sorry, guys. Implementation of minimally invasive extracorporeal circulation system in minimally invasive aortic valve surgery. Results from 156 patients.
Dear colleagues, good morning everyone. I would like to thank MIECTS for giving me the privilege to share with you our experience on minimal invasive extracorporeal circulation system in mini AVR surgery. I have no disclosure. Nowadays, there is no doubt that minimal invasive should be the standard of care to treat patients who require valve interventions. And a minimal invasive program must include, as a surgeon, both surgical and catheter-based approaches. And while we continue to generate always improving short and long-term clinical outcomes in valve surgery, we should also get concerned about perioperative quality of life of our patients and their family. We believe we have to go over the concept that minimal invasive means only a small cut. At present, reduced trauma, rapid recovery, and perioperative quality of life have become key elements to evaluate the results of valve interventions. Based on these principles, we have developed a multidisciplinary minimal invasive approach for treating patients who require AVR in our institution. Our program aims to include in a less invasive way all the components of the interventions and mostly all the health professionals that are involved in the patient's care. This approach includes surgeon with less invasive techniques, perfusionist with an extensive use of minimal invasive extracorporeal circulation system, anesthesiologist using ultra-fast track anesthesia with table extubations that allows to start a very early rehabilitation program just a few hours after the interventions and to establish an immediate patient's family contact. And this is the result. This is a recent case we have done. An 81-year-old lady who underwent mini AVR using MIECTS system. She was extubated directly in the OR in the late morning, and 3 hours later in the ICU, she was sitting on the bed working with the physiotherapist. And this is another picture, an old lady, 3 hours after surgery, extubated, working with the physiotherapist, and we get the daughter beside, supporting the patients. And this definitely improves the comfort and the perception of surgery for both the patients and the family. We strongly believe this is being minimal invasive, and this is as important as the length of the cut. And MIECTS system is a fundamental component of our approach. There are data published showing that MIECT compared with standard CPB is associated with improved clinical outcomes in terms of bleeding, organ protection, and survival. However, such evidence has been reported only in coronary surgery so far, so the impact of MIECTS system in valve surgery remains unclear. In the present analysis, we assessed our 30-day results in patients undergoing mini AVR using MIECTS system. The study cohort consists of 156 consecutive patients who underwent mini AVR using a type 4 MIECTS system in our institution. The study population was a low-risk population. The median Euro score 2 was 1.3%, and the median age was 75 years. All the procedures were performed through a J-mini sternotomy and central cannulation for CPB institution. Operative findings showed a high rate of autologous prime, 73% of cases, leading to a very low rate of transfusions. The median operative transfusions of red blood cells was 0 units, with 70% of patients requiring no transfusion. 30-day outcomes were excellent. The overall mortality was 0.6% and no stroke was observed. Only one patient required surgical revision for bleeding. The median ICU and hospital stay were 24 hours and 6 days, respectively. In conclusions, our results showed that MiECT system can be implemented safely in mini AVR interventions and was associated with very low mortality and morbidity rates. We believe MiECT system should be considered a fundamental component of modern mini AVR approaches, as by reducing the surgical injury and promoting faster recovery, it may further improve less invasive interventions. Thank you very much for your attention.
Unfortunately, Dr. Beretta is my understanding that he's not available to discuss this paper, so I think we'll just move on to the next abstract.
Okay. So the last abstract, which is actually we received the first prize in the award, so being considered the best quality abstract in this meeting. And so the abstract was submitted by Dr. Gunaydin. I hope that I pronounced your name well, and his colleagues. And the title of the abstract is The Impact of Minimally Invasive Extracorporeal Circulation on Myocardial Edema and Microvascular Integrity. Dr. Gunaydin, please.
Hi, everyone. My name is Emre Kuraçoğlu, and I'm working as a cardiovascular surgeon at Ankara City Hospital, one of the biggest cardiovascular surgery clinics in Turkey. And today I would like to present you the impact of minimally invasive extracorporeal circulation on myocardial edema and microvascular integrity. I have nothing to disclose and no conflict of interests. Endothelial glycocalyx is a protective barrier, is a carbohydrate-rich layer lying in the endovascular endothelium. And in healthy vessels, the endothelial glycocalyx determines the vascular permeability, attenuates the blood cell vessel wall interactions, and mediates the shear stress sensing, enables balance signaling, and fulfills the vascular protector role. And shedding of the glycocalyx layer is caused by inflammation mediated by TNF-alpha, ischemic perfusion injury, hypervolemia, hydroxyethyl starch. As you can see here, these are the endothelium, and this is the neutrophilic granulocytes. And as you can see, the brown layer here lying at the outer layer of the cell is shown as glycocalyx. Aquaporin is also a very integral part of the system, and helps to facilitate the water transfer between cells. In 1992, they were discovered, and by which the protein is able to facilitate the transport of water over the cell membrane at much higher rates than simple diffusion could explain. So aquaporin channels do not use ATP for energy, only ion channels need energy. Aquaporin channels only allow transport of uncharged particles via gradient pressure, making it highly effective with no stored energy. Water will move from high to low concentration, facilitated by aquaporins and diffusion. We have a couple studies that are published before, and we look at the different part of this system and inflammatory markers, as we can say, and a syndicon 1 and aquaporin levels. We analyze, expression levels of those in order to understand this system and in order to understand the inflammatory response of cells. And in our study now, our objective is the endothelial glycocalyx is shedding is accepted to be one of the early signs of inadequate myocardial protection due to myocardial edema and inflammatory response. Aquaporin proteins form transmembrane channels helping the transfer of water molecules against osmotic gradients. In our study, we studied the effect of minimally invasive extracorporeal circuits versus conventional circuits on microcellular integrity and excessive volume handling in coronary bypass grafting patients. We had 40 patients. All of them were high-risk patients undergoing CABG, were post-operatively randomized over 10-month periods. 20 patients in each group, and group 1 a MiECT group, type 4, and group 2 is a conventional circuit group. Expression of the aquaporin 4 was analyzed using the PCR and serum syndicate 1 levels as a biomarker of endothelial glycocalyx shedding with monoclonal BB4. Blood samples were collected at the baseline after cessation of the cardiopulmonary bypass at first postoperative day. Transmural myocardial specimens underwent immunoperoxidase staining for aquaporin 4 and syndicate 1 antibodies. This is the MiECT circuit that we use in our hospital. If you look at the early postoperative outcome, the age, male, the BMI, the preoperative SPS scores, aortic cross-clamping time, drop levels, hemorrhage, red blood cell transfusion, respiratory support, ICU stays, and hospital stays. And if you look at all those, there were no statistically different between the outcome between groups. This is the, as you can see, this is the silicon group, silicon 1 levels we looked at in compared those in 2 groups, and MiECT group silicon 1 levels were relatively and statistically actually lower compared to conventional group, which shows a less inflammatory response in the MiECT group. And also myocardial aquaporin 4 level by PCR and expression levels at numerically the aquaporin 4 levels were higher in MiECT group, also showing the better preservation of those cells and better preservation of the cellular edema in MiECT group compared to conventional group. On the left side, you can see the silicon 1 staining. In conventional group, the staining is higher, which shows a more inflammatory response compared to MiECT group. On the right side, aquaporin 4 levels, aquaporin 4, it's shown here between conventional group, and the cells seem to be higher, actually, preserving the more water, which shows that the more edema in the conventional group compared to MiECT group. To conclude, our data confirms the contribution of the MiECT to overcome the hemodilation and less inflammatory impact, leading to better preservation of cellular function and volume handling versus conventional group. And further studies with higher population are warranted. Thank you.
Thank you very much, Dr. This was a very interesting presentation, and I want to congratulate you and your team first. I think that one of the main reasons that this won the first award, because this is a truly level 8 data with a prospective randomized trial, which are so rare in our community of surgeons. We always see a retrospective single center series or a case control study. This is a really true prospective randomized trial. The second comment I had, which is very favorable, is that you looked into the basic science of it. Trying to understand why MiECT may be truly clinically effective. And this is the kind of data that surgeons needs to be convinced to adopt the MiECT strategy. That being said, I have several questions for you, and since we have maybe 1 more minute time because we didn't have previous discussion. So first, just technically, when I looked at your 2 graphs, your 3 time points was baseline, post-bypass, and then post-op in the ICU. So how did you get myocardial aquaporin 4 level on the ICU?
So it's measured in the serum aquaporin level as serum aquaporin levels, but the only microscopic specimens were taken inside the operating room as soon as we come off bypass.
Okay, so those are serum levels of aquaporin. The reason I'm saying this, obviously I didn't understand it, and this is a critical point, because most of the serum aquaporin is not related to the myocardium. As a matter, the vast majority of aquaporin 4 comes from the brain and the nervous system, and very little, if any, comes from the myocardium. So I think that's something that we should all be aware of, looking at aquaporin, and it's difficult to get an idea of what's going on in the myocardium. It actually brings me to the point, because actually aquaporin 4 has gained significant attention in neurological diseases, like similar to optical neuritis and so on. So for future studies, I would look into myocardial perfusion, brain perfusion, because this is one of the major issues we are looking into when you use MIECTS, is to whether we have better brain protection with MIECTS. So therefore, I would just suggest that you look into the brain and brain water and other and brain edema, because that's where aquaporin 4 is really plays a major role, and the role in myocardium is quite controversial. The second question I have for you is why did you choose Syndecan 1? You know, the Glycocalyx is a very heterogeneous layer with the protoglycans, which Syndecan 1 is one of them, but also glycoproteins, and within the protoglycans is heparinase and the chondroitin sulfate and many others, and within the other components is glycoproteins such as the selectin group. And if anything, if you want to assess inflammatory impact, you look into P-selectin, for example. So why did you choose the Syndecan 1 as an indicator of Glycocalyx shedding?
So we had an experience before with working with Syndecan 1 levels, and so we know the methodology. And it's not easy to find P-selectin kits in our country, so Syndecan 1 is much easier to find. And so since we found significant differences in our previous studies, so we think this might be also a practical way to measure Syndecan 1, but you're right, so P-selectin might be a better choice.
But particularly that you really want to look into the inflammatory component, or the reduction of inflammatory response. So you had the conclusion that you reduce the inflammatory response to bypass by using MIECT, but I'm not sure that's very well based on the data you have. Dr. Sirico, any other comments on this? Because this is like
I just have a short question. What kind of cardioplegia was used, and how was your volume management?
So in all of those, we used blood cardioplegia, and in every 25 minutes.
And how was the volume management?
Well, so we always use ultrafiltration at the end of cardiopulmonary bypass.
Well, for the interest of time, I think that will conclude this abstract session. Please stay tuned for the industry forum.
Good evening, everybody, dear colleagues, dear participants. It's a big privilege for me to open this session, this so-called industry forum. My name is Hans Jenny. I'm the chief perfusionist from the University Hospital in Bern. And yes, we practice MIECT since 20 years ago. Type 1 for CABG is well established. And I think if we want to go further to open heart surgery, this more close collaboration with the industry will be really build the basic for coming forward to penetrate into more market. And so it's a big pleasure for me to introduce two representatives from the two manufacturers which we work very close since the last 2 decades. One is Michael van Driel from Medtronic, and the other is Andreas Becker from Terumo. And now we have 50 minutes, so I think 7 minutes for each, and then on the end, perhaps you have 2 or 3 questions. Now, I want to give the floor to Michael van Driel. Please, Mike, the floor is yours.
Well, thank you, sir. Can you guys all hear me okay?
Yes, I can hear you.
Perfect. Okay. Well, look, I'd like to thank everybody for the opportunity here to just kind of talk about what Medtronic is doing. And I know a lot of you know me, and that I'm fanatically dedicated to the advancement of mini bypass. So it's a pleasure for me to be here, and thanks for that introduction, Hans-Jörg. You as one of the people that's just as fanatic about this as I am. So, Medtronic, I think, just it's fair to say over the last 5 or 6 years that, we've done quite a bit to try and advance the state of the art, not just within perfusion, but everything within cardiac surgery. So we look at cardiac surgery in the same way that we look in teens. There's the part of Medtronic that services the anesthesia side of what we do. There's the side that we do with perfusion, as well as the side that we do with you guys as surgeons. And we have really revamped our entire product line. I mean, even down to AF and ECLS, especially, which was especially important during this whole period with COVID. That really helped us kind of advance the state of the art with the introduction of some of the ECLS cannula, the life support catheters, as well as our new ECMO oxygenator, the Nautilus, through our partnership with MC3. We've also launched the next-gen femoral cannula, and why that's particularly important is that there was a lot of discussion here around ISMICs, certainly around MIECTS. Those cannula we would consider state-of-the-art for adequate drainage and adequate flow support. But when you start looking at more specific things around what is Medtronic's philosophy, yes, we're bringing out new products. Yes, we're partnering with companies that are exceptionally sharp at technology development, like MC3 and more importantly, like Spectrum Medical. But what's also important is that that you guys understand there's also a pretty heavy commitment that's coming from us in industry about trying to keep the products that we already have on the market, in some cases that we've had on the market for quite some time, keeping those products on the market. And what I mean by that is that, for the MDR, for the new medical device requirements for us to keep our CE mark, and for us to be able to keep these products that are available in countries like Canada through our CE mark, not through the FDA approval, but actually through CE, it's vital for us to be able to reinvest and make sure that we're keeping the entire portfolio from the 1,300 components that we have available for the custom packs, the 840 different codes that we have in our catalog for cannula, our new Autolog system, the Autolog IQ, everything that we do on the perfusion side, and as well as in the cardiac surgery side, the requirements around the MDR are pretty heavy. In some cases, the reclassification of the cannula has actually required that we do registries or that we do post-market clinical assessments that are essentially clinical studies. But why that's important is that it relates to everything as it relates to MIECT, but also mini bypass, but everything that we do, to the point that if any of you in the audience or any of you on the faculty, should you guys require written confirmation about our commitment to keeping this product line intact across cardiac surgery and what our intentions are in terms of making sure that we are keeping everything on the market. You can certainly reach out to me directly, and we can prepare a letter for you, for the administration. And my ask to you is that you would ask the manufacturers across the board, not just us, to reaffirm their assessment, to reaffirm their commitment to cardiac surgery in the same way. I think we're being pretty above board and transparent about how we're trying to do this, and I'm sure some of the all the colleagues that I have, with the other within industry would be able to give you the same kind of a commitment. But coming back to what we always say about how can you implement mini bypass, and that I think the MIECT-IS has done such a great job in developing the concept of 1, 2, 3, 4 class systems. What it really comes down to is teamwork, and that's a key part of it. The techniques that you guys have talked about today and some of the clinical evidence that is also key, but it's the technology that continues to advance the state of the art in this. And probably the most crucial platform on being able to do any kind of mini bypass or any kind of MIECT, the real fundamental heart of the system isn't just the disposables, but it's how the equipment, how the heart-lung machine is designed. And as Cyril had pointed out, a lot of the systems that are coming out now, especially the ones like what we just came out with through Spectrum Medical, they're all software-based, which means that yes, we can get it to a point where it's comparable to the mini bypass systems that we've had in the market. But what makes this super exciting is having the technology that we can use electronic clamps that we call occluders, that are smart occluders that can be looped back in the software. We can start looking at doing other things like automating volume return, automating just volume displacement based on pressure, based on flow. There's a high degree of the ease of use that we can start looking at doing because we have a software-based system like this. And because, quite frankly, the guys at Spectrum are really, really good at developing new modules and being able to develop this technology in a fast way. I got to give credit to Pascal. I told him I was going to use one of his slides because he's done just an outstanding presentation for us in our options and outcomes meeting that we're doing virtually in a couple of weeks. But it really does kind of show that, when we put in a system that is still designed with the same concept as what we're trying to do, where, we want the quantum heart-lung machine in a mini bypass application. We want to be able to use it with anybody's disposables, right? It's not just capturing a captive disposable, aside from the centrifugal pump, obviously. But the idea is to be able to design it so that it can be used with anybody's bubble trap. Certainly our VARD system, we think it's the best on the market and it's the most efficacious, but having something that is a little bit more flexible to make it in the same philosophy that we've done with the monitoring systems here, where you're no longer you're no longer stuck with a captured disposable for measuring saturation or for measuring hematocrit, PO2, PCO2. We're going with the same philosophy here around how do you manage error. And being able to do it manually, being able to do it in an automated way, using the flow and bubble sensors combined to be able to do that. And what that means is that as the next step, what we're expecting to do is start looking at being able to take these other automated flow pathways that we've already got created within the quantum heart-lung machine, being able to apply that now to a completely closed system or to a hybrid system, so that we can now start doing volume shifting. We can start doing automated volume return based on negative pressure. We have ramp down, zero flow, all the standard feature sets that we have, but making it easier to adopt this kind of technology more rapidly to a clinical use. We also just came out with a new Cell Saver, the new Autolog IQ. We're really proud of the system. It's essentially a better version of the IQ. It's a more updated version. The IQ is a more updated version of the old Autolog system. This is a technology that we're we really believe in. It's a 2-wash pulse wash cycle, unique to our bowl, unique to the IQ. And we've got some extra capabilities that we'd always wanted to put on the original Autolog, including being able to do pediatrics, partial wash, being able to give the volume back in the middle of the cycle if that's what you want. But we're really happy with the system and with its clinical acceptance over the last year. This is particularly important in terms of technological advancements. Look, this is relevant to cardiac surgery, regardless if it's mini bypass or regular bypass. Just so that everybody knows that we are now launching the Mr. Frosty system, which is a heater cooler that's using a non-infectious glycol solution. So it means that we do all this work for mini bypass, but we don't have to struggle or concern ourselves with having done all that work only to have this patient get an infection because of the exposure to water-based heater coolers used in the operating theater. We just started clinical use with this product over the last 6 months, and we're really excited about the initial clinical results. There was some discussion about NIRS and about cerebral monitoring, and obviously the former MITG, another division within Medtronic, is we're now collaborating with them more aggressively on being able to do cerebral perfusion monitoring. But what this really does come back to is something that Philippe had actually mentioned as well. No matter what the technology that we come out with, it's really crucial that we continue the education, the training and education piece. Medtronic has always treated training and education almost like another obligation, another product. So for us, there's no difference between promoting a therapy and promoting the training and education piece. Now we have mini bypass courses set up, with Bern. We've got a class on demand should it be needed in Braunschweig, where we're now doing a great and a really, really interesting course thanks to Pascal and his team in Hassel. Combining mix with mini bypass, which really kind of helps us do the best on both sides of the let's say of the heart-lung machine for the patient, and of course our course that we do here with Thessaloniki, that we're also going to be taking these courses virtual, and we call it virtual presence, meaning that we can actually have people be behind the computer, but actually interacting with on something more sophisticated than a Zoom platform, but being able to actually feel like they're in the operating theater without actually being there. With that, I'd like to thank the entire group for allowing me this time. I hope I haven't gone over, but hopefully, just to reiterate our message around what we're doing with our commitment to product development, to technology. From our side, we're going to continue to develop this, especially in the mini bypass applications. You have my word that it's not just about future developments, but it's also about making sure that we're keeping the product portfolio intact, which is even more important considering the MDR. So thank you.
Thank you very much, Michael, for this for your engagement. We know you're sincere, and I'm really happy to have you as a partner for MiECT. It is also a commitment what you do with Spectrum. What I heard about volume shifting and all that, to really hit the point. That is really that we need for the future to penetrate into more into market. So thank you very much for that. So the next speaker is Andreas Becker here from Terumo. He will please, Andreas, the floor is yours. Thank you.
Thank you very much, Hans-Jörg, for the kind introduction. I hope you can hear me well.
Yes, we hear you.
Perfect. So I'm always very pleased to be a member of this interesting symposium. It's always great to be part of it. Actually, I didn't prepare any slides for the meeting today, and want to use my time to talk more in general what the role of the industry can play in terms of the MiECT concept. And I believe everybody has noticed there was a lot of discussion already today about adverse effects related to cardiopulmonary bypass. And even so, cardiopulmonary bypass has become a standard procedure with very little mortality. Nobody can ignore that even today there are still these adverse effects present, and probably we will never be able to fully eliminate them. But here I see one important role of the industry to keep improving the equipment that we are providing to you to do your minimal invasive extracorporeal circulation. And there is already a lot of clinical evidence available that MiECT technology can reduce these adverse effects. Even if we look at existing clinical practice guidelines, regardless if we check the STS or MSEC guidelines in the United States, or the recently published guidelines in Europe, they all meanwhile recommend low prime or minimized circuits or MiECT circuits. So the expressions sometimes are different, but all these standards recommend the use of minimized prime circuits, closed systems, biocompatible systems to reduce these adverse effects of extracorporeal circulation. So if we look what as a company we can contribute, we first of all need to acknowledge that the MiECT is a very complex and highly customized field. So I find it very difficult to develop one product as a company that would be suitable for all the different applications, keeping in mind that I believe every hospital is using a slightly different concept. We provide a standardized system, and I was very pleased to see that this system was used for one clinical study presented in one of the award-winning abstracts. But this is more the exception. We are selling many more customized MiECT circuits than we sell our standard configuration. And therefore, we are putting a higher focus on the individual components and leave freedom to the user to combine and select the components that fit best to the existing clinical protocol and the daily practice. Being a representative of Terumo, I think I can say that our core competencies are in the field of oxygenator technology and also online blood gas monitoring. We have a very long history in developing oxygenators. It's almost 40 years since we launched the world's first hollow fiber oxygenators. That was in 1982. And since then, in the history, there have been many world's first developments. We have been the first company to fully integrate the arterial filter inside the oxygenator. So full integration means to put it inside the oxygenator housing, not requiring a own housing and not requiring extra priming volume. We also launched the world's first pediatric oxygenator with an integrated arterial filter. And until today, we produce the smallest oxygenator, so lowest priming volume oxygenator for small adult patients. So these are milestones, and I believe that our oxygenators are a perfect choice for minimized extracorporeal use. For us in Terumo, MiECT also includes extended advanced monitoring. We believe that monitoring is needed to react quickly in case one of the important blood parameters is moving out of the physiological range. And so you need to have online data to react quickly and avoid any major deviation from a physiological situation. And there probably everybody knows our established CDI technology. The latest version allows monitoring of 12 essential blood parameters in real time. We now included also DO2 monitoring so that you can follow the goal-directed perfusion approach, which is definitely helping to achieve better patient outcomes. So looking into the future, where do we see this MiECT concept going? Certainly as an industry partner and also seeing all the recommendation in the clinical practice guidelines, we certainly pay high attention. And with every new product development, we have the MiECT idea in mind. So we always try to improve biocompatibility, to reduce priming volume, to improve the air handling of the components, the elimination of gaseous microemboli, for example, we see also as a major part to improve the biocompatibility of the circuits and to reduce these adverse effects. So development of new product is not getting any easier. Also, Mike already mentioned the MDR guidelines. It's tough for manufacturers. It requires a lot of additional investment, documentation, and research. But like Mike said, Terumo will also stay committed to the cardiovascular field, and we continue to develop products. Also, and I can only echo what Mike said, I also see it as a task of the industry to educate our users and to train our users. We have also training facilities available around the globe. We also have started a series of webinars where we invite healthcare professionals to present, for example, on perfusion safety, present daily examples, case studies, to present on the guidelines, to make sure that everybody is informed and also the knowledge in the field is growing. So this concludes my presentation. Thank you very much again for the invitation, and I'm also open to questions you may have. Thank you very much.
Thank you very much, Andreas. Sorry for that, because we are a bit under pressure because of time. I just really appreciate your products, especially your oxygenators. So sorry for that, because we have to move forward, and I have to give the word back to John for the next session. So thank you very much.
Thank you, Hans-Jörg.
Good, thank you. And just in a moment, we'll be having an update on the comics trial. So just bear with us.
Good afternoon or good evening, according to whatever you are in the world. What I'm proposing to show in the next 5 minutes is an update on our comics, the prospective randomized study. Just for the one of you who may see this for the first time, the aim of this randomized study is to test the hypothesis on the effectiveness of MiECT, and of course also on the cost effectiveness. The objective are to estimate a difference in percentage of participants having primary composite endpoint at 30 days, and I'll come to the endpoint in a minute. And then of course we look at secondary outcome and cost effectiveness. More or less any patient above 18 up to 25 is included, and there are 3 different types of surgical procedure required for enrollment of patient. One is CABG, isolated CABG. The other one is isolated AVR or combined AVR and CABG. No other procedure were allowed in the study, and of course emergency crushing procedure criteria, as well as major aortic surgery, congenital or acquired platelets deficiency, and so forth. Now, to avoid confusion, which has been quite common in the past when describing a minimally invasive setting, we have established very clear guideline, which has to the device has to be a type 2 or higher, as according to the description of anesthesiitis in perfusion 2015, And of course, it is necessary then the team on the participating center have got enough experience in relation to the use of the MiECT technology. As far as the cardiopulmonary bypass, the conventional cardiopulmonary bypass, that is very much what you would say standard, with the exception of soft-shelved reservoir or vacuum-assisted venous drainage, which obviously is not allowed. Otherwise, you end up more or less with a mini bypass anyway. Now, this is probably the most important slides of the 12 composite endpoint. We deliberately choose endpoints which are clinically relevant. In the past, there has been a lot of work done comparing minimally invasive cardiopulmonary bypass with conventional, like looking at inflammatory markers or various organ response. What we choose here, we think, is very important in terms of making a clinical difference. You can see for yourself, but obviously death is pretty relevant. Myocardial infarction, intubation, tracheostomy, gut infarction, stroke, reoperation, etc., etc. As you see, 12 very solid, very clear clinical endpoints. And secondary endpoints, blood transfusion and blood loss, ITU, hospital stay, and so forth. And this is the scheme of the trial. The sample size, which was calculated, was 3,500 patients with a risk ratio of in target difference of 0.75. Right, these are the centers which have been involved in the study. It's been a progressive enrollment. Unfortunately, Plymouth had to withdraw from the study. Bern has not entered any patient now for a rather long time. We're not quite sure what the situation is. We've been trying to clarify this. But at the same time, Toronto started a few months ago, the same for the Hammersmith, and anytime now, Göttingen also will start recruiting. The main problem with the recruitment has been that we started, as you can see, quite low. This is April 2018. And then as we got to 19 and we were ready to have a go and sort of go up, COVID hit us pretty badly. And there is no question that the problem is still persisting. And these are just some figures, the most recent figures. We now reach a total of 920 cases, in fact, a bit more than that. This was to the 31st of May. But as you can see, in the middle of the second wave or third wave for some country of COVID pandemic, in January, we only randomized 13 patients. We seem to have increased a bit in May with 38 patients. This is a distribution of the hospital, which have contributed to the recruitment to the study. And as you can see, it varies rather a lot. And this is the Euroscore. I won't spend any time discussing the Euroscore, but you will see from this that the patients who have been randomized seem to have what you would describe a lower to average Euroscore. And this brings me to this, which is probably the most important or one of the most important slides. This is the primary endpoint. Now, the primary outcome rate is at present around 10%, which is not quite what we were expecting when the trial was developed and the sample size was actually calculated. So this was done on the base of a previous large randomized study run in Bristol, Tither 2, which had an event rate, a primary outcome rate of around almost 14%. So what is the present situation? And this is my last slide. First of all, it's been an enormous team effort, and we are most grateful to all the units who have participated out of really their goodwill. because except for some grant money from companies, this is a study which is being run entirely on goodwill, and we now achieve almost 1,000 patients. The frequency of the event, as I said, is 10%, which it doesn't quite fit now with the sample size of 3,500 patients. And in fact, if we were to maintain a 90% power, we would require a sample size of 4,750 patients. The other problem is the slow rate of recruitment has created a situation that even if we hit 50 patients per month, which is actually quite possible, providing then COVID doesn't hit hard us again, it will take another 4 years to complete a study which started almost 3 years ago. So where do we go from here, or what do we hope will happen now? Of course, the first things we hope is then COVID, if it doesn't disappear, at least is manageable, and most units will be able to go back to their usual load of work and hence recruit in a more significant fashion, which brings me to the second point. We have seen an increase, but we need a much higher recruitment rate. We really need to hit at least 100 patients per month. There also have been a suggestion about some potential changes to the trial protocols, but we're happy to go into details if people wish to ask questions. This is a decision which is not up to us as the people running the trial, but to the trial steering committee. And certainly the idea of changing the protocol, like the primary outcome, was not approved really by the committee. So this is in short the most recent report with some good and some not so good news. But the main message I want to give out here is a great thank you to all the center who have so far allowed to develop and deliver a trial which at present with 1,000 cases is the biggest has ever been done in this particular area of research. Thank you.
Thank you very much, Professor Angelini. This session is open to questions. People want to ask about the trial. I work with Professor Angelini to manage the trial. I can give some more details about the feedback we've had from the DMSC and TSC chair if that's relevant. But has anybody any questions? I'll just say that the proposals, one proposal was to add to the composite outcome to add lesser degrees, lesser severity of acute kidney injury. Both the TSC chair and the DMSC chair felt very strongly that we should that would undermine the hard work that everybody's done when we come to publish the findings. In other words, it's better to stop early for reasons of feasibility or logistics, if that's what we choose to do, rather than to manipulate the trial protocol to produce a trial that looks right, but which isn't in agreement with the protocol that we set out at the beginning. Another suggestion was about reducing the power to 80%. They were less sure that that shouldn't be done. I mean, that could be done, but that still leaves us with the target sample size of 3,500 to reach. I think the most important thing is that there is a plan about what to do. Perhaps not immediately, because we're still affected by the pandemic, and so we don't know what recruitment is going to end up at per month. But by the end of the year, I think it's important that there is a plan of what to do. A final suggestion was about the futility, about doing an interim analysis. And the view there was that an interim analysis might help, but there still needs that achievable plan, or there needs to be a plan for the trial to be achievable before you do that interim analysis. There's no point doing the interim analysis if we're going to stop early anyhow. I'm sorry, that wasn't my best explanation. Anything else from anybody?
I think that's excellent, Barney. It's a very nice summary of where we are to date. And I think we'll have to stay tuned for further updates as we deal with this challenging problem of the recruitment rates. I think now we have a brief time for the General Assembly. Professor Ennis, and it is going to we're going to do the formal handover of the presidency.
Yes, I think Polychronis as the secretary has now the lead.
Thank you. Thank you. I will just share my screen just to remind. So I think it's okay. It's an evaluation report of a very, very tough period. I would like just to remind you that we have gathered in Thessaloniki in 2019 for the second MIECTS live update meeting, and then it was Canada in Niagara Falls, which was a little bit drawn by the COVID pandemic. And this was substituted by the MIECTS Live 2020, which was the first virtual, let's say, strong virtual event of the society. And there was a very good correspondence from the perfusion community, the surgical community, and the anesthetic community. So it's now time to pass on from the previous steering committee with John Merkin, president, and Cyril Serik as the vice president that served 2018-2021. There was a one-year extension to the 2023 committee with Cyril Serik, the president, Serdar, the vice president, and replacing John Merkin that moves to the executive board. It's Gabor Ardoes, cardiac anesthesiologist from Inselspital University Hospital in Bern, and we're very, very happy to have him with us as a MIECTS steering committee member, and we strongly believe that he will contribute to expanding MIECT technology. So regarding the future events, there is the live MIECT update meeting in November 2021. So you're all invited there. We will have the chance to discuss in depth, and I hope live, not virtual, but live, all the new developments in MIECT technology, and the live, the real for MIECT Symposium in June 2022 in Canada. So I'm passing the baton to you, John and Cyril.
Good. Well, thank you very much for those comments, Polychronis. As the past president, as of now, I want to just acknowledge the fact that while the first two presidents were both cardiac surgeons, as a cardiac anesthesiologist, I feel very privileged to have been the president of this multidisciplinary society. And as we see, we're continuing on now with the new president, Cyril Serik from Toronto, a perfusionist. So really, this is a demonstration of the truly multidisciplinary nature of this society. and as we keep emphasizing, it reinforces the fact that successful application of the MiECT strategy really is contingent upon having a team approach. I don't know if we've got time now. I can just screen share just to make a few final comments. I would like to say that we have now got, as we've heard, we can look forward now to another live update meeting, which will be coming from Thessaloniki in November of this year. And these have been very important sessions. And I think this is a very key way in which this international society can continue to communicate and receive these important updates and points of discussion. From my standpoint, I would like to really thank, first of all the speakers for their participation in this event. I think it's important to acknowledge the role of live media in sponsoring what I think has been a very, very logistically challenging, but from my standpoint, certainly a very successful virtual meeting. And this is just a reminder to all of those registrants who are with us currently that, again, all the lecture topics are archived on CTSNet and on the MiECTS website, so that if we've piqued your curiosity, one can go back and review particular topics. Very important, I think, always to acknowledge our sponsors, Medtronic and Mike Vandriel particularly, but certainly the support of Terumo and McKay with these initiatives has been very important. And again, the hand-in-glove approach with clinicians and industry to help move this whole technology forward, I think is one of the keys, and again, what makes this society so particularly important. I'd like to briefly just again review the leading abstracts, and I think what we're seeing now is the investigations looking at venous tone, which was Mark Bennett and his group, talking about the impact of low-dose vasopressors to maintain vascular tone to help improve venous return. The thing that struck me about our second prize winners from Ancona in looking at this whole strategy has been the involvement of the family in the postoperative recovery phase. And I think that's a subtle, but I think very important role that I think we'll see, particularly as we move to fast track, and in our case, ultra fast track extubating patients on the table. The fact that family members are available in the critical care area to see the patients postoperatively is key. And I think most importantly, a tremendous acknowledgement of the work from Professor Gunadin and his colleagues. I think these new strategies looking at the glycocalyx and the impact of MIECTS circuits on preservation of the glycocalyx is really a key to understanding some of these observations that have been made about less edema in the patients, less inflammatory responses. And I think now we're really starting to target the actual mechanisms by which these clinical outcomes are manifest. So once again, I'd like to thank you all for your participation. I'd like to give you a big reminder that hopefully third time lucky, the actual fourth International MiECT Symposium, live symposium, was originally going to be in 2020. It was going to be this year. We keep getting stymied by COVID, but we are optimistic that the third time will be a charm. So I invite you all to attend the meeting in Niagara-on-the-Lake in June next year. We have a lovely hotel booked. There's the Niagara region is really one of the most beautiful areas in Canada. Everything from Niagara Falls through the local wineries, and Niagara-on-the-Lake is a charming colonial town, which should be a very a warm welcome to all of you for next June. So please mark your calendars, stay tuned, and I'd like to thank you all for participating in this event. Thank you so very much.